Okay, welcome back. And thank you all for being on time. Welcome back also to our 3,400 plus viewers, webcast viewers today. If you are joining us for the first time, we have a full afternoon planned for you, which includes polling sessions and evaluations. So if you have not reviewed the polling instructions, please review them, the polling instruction document that is posted on the CTEO website. Also note that if you have questions for the presenters this afternoon, that you can send them in via the SurveyMonkey link that is also on that sheet of paper that is on the CTEO website. Our next speaker will start us off this afternoon by providing us with an understanding of the revisions made in Chapter 6 of the Medicare Prescription Drug Benefit Manual, as well as respond to questions received about the update. It is my pleasure to introduce to you Lieutenant Commander Marie Manteuffel and Robert Dombrowski.
Good afternoon. I am Lieutenant Commander Marie Manteuffel. I am an officer in the U.S. Public Health Service, Commissioned Corps, and serve at CMS in the Division of Part D Policy. As you just heard, I'll be presenting this afternoon on the recently revised Chapter 6, and about halfway through this session, I'll be joined by my colleague Bob Dombrowski, who will speak more to the formulary updates, formulary reference file, and utilization management. Our agenda for this session is noted here, and it was suggested we needed a catchy title, especially being right after the lunch session. So without further delay, Chapter 6, the Part D Formularies Awaken. Okay. Chapter 6 is a key reference for Part D sponsors on the administration of the Part D program. The first Chapter 6 came out for comment in 2006, the first year of the Part D program, and it has grown and been revised over the last 10 years. The chapters are available online through the online manual system. And here's a screenshot of the cms.gov page on manuals. From here, you can see where the red arrow is pointing. You would click on Internet-only manuals along the left-hand side of the screen. When you do that, it will take you to the different listing of the publications available. And under Publication 100-18 is where you'll find those specific to the Part D program. So when you click on 100-18, you see the table of contents for the various chapters available. So here in front of you, this is the 2016 version. You should see when you're pulling this up, the red date underneath should say 2016. That's our most recent version. And consistent with past revisions, this revision covers three main areas: definition of a Part D drug, Part D exclusions, and formulary requirements. There are also 4 appendices, which include a Part D drug summary table, a discussion of B versus D coverage issues, a list of the most commonly prescribed drug classes for the Medicare population, and new in this version specifically, a listing of various scenarios when transition supplies may or may not be warranted. So to start the revision process, we did some redlining. And looking back over the last few years, we wanted to see what policies have changed, what memos have been issued, what call letter policies have been announced, and what regulations have been finalized. And with that, what needed to change and be updated in the Chapter 6 to make it current with current policies. I would like to stop here and truly thank everyone who reviewed and provided suggestions during this process. Feedback was extremely helpful, and comments were carefully considered before finalizing this version. Since this was such a comprehensive revision, we also took the time to clean up some formatting and grammatical issues. So when you open the chapter and you see some different language in red that appears new, it might be less about a new policy or a revision. It might just be grammatical or verb tense or list formatting issues as well. Okay, so starting here in the following slides, we'll walk through some, but not all of the sections with revisions in this 2016 update. When you access the chapter online or download it, you'll see any of the new language in red text. So we'll start with section 10.3, commercially available combination products. This section was updated in line with changes made in the final Part C and D rule in 2014. Notably, we wanted to clarify this section applies to commercially available combination products meant for broad distribution. It does not apply to extemporaneous compounds. This section is more talking about kits or bundles where multiple units or items are packaged together and intended to be dispensed as a single unit. Okay, so if you can get your voting device ready, we have our first question for the audience. So consider this scenario. A new hypothetical drug, Super Strong Bones plus B, was just approved and hit the market last month. Mrs. Jones arrives at the pharmacy with a prescription for Super Strong Bones plus B. Is this a Part D eligible drug? And I will hold here for a minute while you log your votes. We see B growing, C. Okay, so we're seeing a lot of variety in the answers, which is great. We kind of made this one a little tricky on purpose. So to think it through, if the FDA approved Super Strong Bones plus B in this combined form, whether both ingredients are in one tablet or whether they're separate in separate bottles but being dispensed together as a kit, if it was approved in that form and it is approved for Mrs. Jones' condition, then yes, a Part D plan could cover this drug. So the correct answer, there's some truth in A, some truth in B, but really for this section, what we're looking at is that Part C part. It really depends on how the kit or the package was approved by the FDA. So thank you everyone for voting. Moving on to section 10.4, this is the section specific to extemporaneous compounds. Some of the updated Chapter 6 language is included here on the slide in front of you. And to give one example, looking at the second bullet, for a Part D compound to be considered on formulary, all ingredients that independently meet the definition of a Part D drug must be considered on formulary. Said another way, a claim for a compounded drug needs to be treated as one claim. It's either all on formulary or not. Even when the sole Part D ingredient is on formulary, a sponsor does not have to automatically list any compounds with that ingredient as on formulary. Sponsors can choose to only cover compounded medications by exception. So if you want to get your voting devices ready, again, we have a true-false question. True or false? Part D sponsors must consider extemporaneous compounds including at least one Part D eligible ingredient as on formulary. And we'll hold here for a minute. So it looks like a pretty even split so far between the people responding. The answer for this one is false. Sponsors technically do not need to consider any extemporaneous compounds as on formulary, and instead may choose to review individual ingredients and medically appropriate indications on a case-by-case basis. Section 10.4 in the chapter does go on to offer sponsors guidance on how to handle both formulary and non-formulary extemporaneous compounds. So moving on to section 10.6, medically accepted indications. Part D sponsors must reference all CMS recognized compendia to determine whether there are any supportive citations prior to determining that a drug is not being used for a medically accepted indication. And bullet number 2, all Part D sponsors should consistently utilize prior authorization for those drugs with the highest likelihood of non-Part D covered uses, as detailed in section 30.2.2.3, unless plans are able to reliably use tools other than PA to determine appropriate coverage for the drug. In section 10.6, we talk about Part D sponsors' responsibility to determine whether a drug is being dispensed for a medically accepted indication. CMS is not at the point of requiring PA on all drugs to confirm diagnosis. Consistent with documents CMS has issued previously, we do ask sponsors to consider their experience with determining MAI and to utilize PA or other reliable tools or available documentation to make determinations about those drugs with the highest likelihood of non-Part D covered uses. There is not one be-all, end-all list of drugs. Rather, we look to sponsors and their P&T committees to thoughtfully consider their experience with the program and to balance the appropriate use of PA and other tools. And as noted here and in the chapter, there's more detail in section 30.2.2.3, which we'll touch on in a few slides. So another voting question. In this scenario, would this drug be for a medically approved indication? So this is a little confusing. I'm not sure if it's back on the other slide. Okay, so I will read the scenario. It didn't appear here. So in the case of a drug where the indication is not on label, the indication is supported in AHFSDI, but is not supported in drug decks, would its use be considered medically accepted? So I'll say that one more time since it's not on the screen. The indication is not on label. The indication is supported in the American Hospital Formulary Service Drug Information Compendia, but is not supported in drug decks. Would that use be considered MAI? And it looks like a majority of the people responding did get that correct. Yes, if there is support in one of the recognized compendia, this would be considered MAI. Moving on to section 10.6.1, retrospective determination of a medically accepted indication. When retrospective review of point-of-sale claims adjudication determines that a drug was dispensed for a non-medically accepted indication, the PDE should be deleted and accumulators adjusted. As stated here on the slide, we highly encourage everyone to review also Chapter 18 on this topic, and there were also some guidance documents from 2013 released related to this from the Medicare Plan Payment Group for more information. And so again, just multiple publications, multiple online resources to be considered. So sticking with the same section just for another minute, what's on the screen in front of you is an example taken straight from the chapter, so just to kind of walk through what this looks like. When it's not reasonable to expect a Part D sponsor to require PA to ensure that a drug is being used for an accepted medical indication, CMS would not expect the sponsor to recover payments made to pharmacies or attempt to obtain reimbursement from enrollees. However, when retrospective review of POS claims adjudication determines that a drug was dispensed for a non-MAI, the PDE should be deleted and accumulators adjusted. And again, I'll point you to Chapter 18 and 2013 guidance previously released on these topics. So moving into the next section, section 20 of the chapter, we'll begin with section 20.1, Excluded Categories. There weren't a lot of changes to this section generally, but I'll draw your attention to the second bullet on the screen, which is some revised language that was used to clarify coverage around cough and cold medications, given the number of questions we receive on this area specifically. To restate some previous guidance on this issue, any prescription medications containing a cough suppressant are not eligible under basic coverage. For prescription medications containing an antihistamine, with or without a decongestant, but not including a cough suppressant, these could potentially be covered if being used for allergies and not being used for cold symptoms. It is up to the plan sponsor to use the tools at their disposal to confirm a medically appropriate indication. So we have another voting question at this point, another true or false. A standard Part D plan may cover a nasal decongestant for a member with a history of diabetes, high blood pressure, and gout whose breathing is labored due to lasting congestion from a head cold lasting 2 weeks. So I'll hold here while you vote. And it looks like a majority of people are getting this right as well. The answer is false. In this scenario, the decongestant is being used to treat cold symptoms, which is an excluded category. Moving on to the next section, 20.2. This is pertaining to drugs covered under Medicare Part A or Part B, notably hospice or end-stage renal disease. These two topics have been presented on in previous conferences, and we would point you to the exact language in the chapter here. It was revised largely in line with guidance released in 2014. Moving on to section 30.2.2, Formulary Benefit Management Tools. In a few more minutes, my colleague Bob Dombrowski will be speaking in much more detail about formulary and formulary policies. But I did want to briefly note some changes made in section 30 of chapter 6. Of note, the language in front of you, while this is not a change in policy, we clarified that when an issue related to a POS edit is resolved at the point of sale, allowing the claim to adjudicate under Part D, the claim transaction does not constitute a coverage determination. Conversely, in situations where the patient or prescriber makes a verbal or written request for coverage of a drug subject to prior authorization or other restrictions to the plan sponsor, that is a coverage determination, and the plan must process it accordingly. And again, I'll point you to Chapter 18 for additional details. Also in Section 30 of the chapter, in an attempt to make clearer what types of edits do and do not need to be submitted to CMS for approval, we broke this down into a few additional subdivisions. So in Section 30.2.2.1, we more clearly identify the 3 types of POS edits: hard, soft, or message only. We added additional language to detail for sponsors the differences between PA, step therapy, and quantity limits. And there's also new language about opioid-specific safety edits. In section 30.2.2.2, we talk about edits not requiring CMS submission and approval. This includes information on some safety edits, as well as cumulative acetaminophen or APAP edits. And the next section, 30.2.2.3, is talking specifically about application of prior authorization. And back on slide 16 was when we promised more information on what was meant by highest likelihood of non-Part D covered uses. The bullets here on this slide list 3 areas of note: high likelihood that coverage is available under Part A or Part B, high likelihood that the drug is excluded from Part D coverage, high likelihood of use for non-medically accepted indication. We've discussed each of these already. Also, this section of the chapter goes on to list non-allowable practices, specifically things that cannot be included, practices that cannot be done relating to prior authorization forms. Moving on to section 30.3.3.1, we wanted to note section 30.3.3 pertains to mid-year formulary changes. We've received a number of questions confusing mid-year with year-to-year changes. Again, I won't get into too much detail before Bob on formulary changes, but I will just note that in this section specifically, 30.3.3.1, we provide additional detail on what constitutes a negative formulary change, which you can see defined here on the slide. Unlike positive formulary changes, which we note can be implemented immediately, such as when a new drug hits the market, negative formulary changes after the start of the contract year are more concerning, so we have additional details here. For example, in the definition above, you'll see that we would consider a drug going from Tier 2 to Tier 4 during the course of the year a negative formulary change. Similarly, we would consider a mid-year plan change from a 60 pills per 30-day quantity limit to a 30 pills per 30-day quantity limit as a negative formulary change. Both would be subject to all formulary change notice requirements. So sticking with this section just a bit longer, we'd like to clarify additionally based on some questions we received after the publication. This passage specifically, and I can give you a moment here to read it, this passage refers only to approved exceptions, not prior authorization. I will say that again. This section refers only to approved exceptions. If the duration of the plan-granted exception is included in the original exception approval letter to the member, the plan does not have to notify the beneficiary again 60 days in advance of its expiration. So for example, if the plan sent a letter stating, Mrs. Jones, your prescription for 2 tabs daily of the 10 milligram strength has been granted an exception and will be covered through the end of this year. That plan does not need to send a second letter on October 31st reminding Mrs. Jones that that expiration is expiring. However, if the plan sent a letter only stating that the prescription for 2 tabs daily has been granted an exception, that plan should send a second letter reminding the beneficiary when the exception expires 60 days in advance. Lastly, we wanted to remind plans that at this time, mailed hard copy letters sent via first-class mail are the only way to satisfy this notification requirement. From here, we'll move on to section 30.4, transition. The bottom line with this, the purpose of the transition policy is to address situations when an enrollee's ongoing drug therapy could be potentially interrupted by a drug being non-formulary. However, just because a member's drug therapy could potentially be interrupted does not mean that the member will necessarily receive a transition fill. I would also like to clarify the above text based on questions we received after publication. This passage above, notably number 2, refers again only to approved exceptions, not prior authorizations. Whenever the exception expires, a member would be eligible for a transition fill, whether the member was informed of the exception in an initial determination letter, or if they were notified when the plan sent a second notice 60 days prior to the exception's expiration date. Of note, this does apply to exceptions expiring mid-year. To give another example, if Mr. Smith was authorized a 6-month exception to cover drug X, if Mr. Smith goes to fill another supply of drug X 7 months into the plan year, assuming that exception started on the first of the year, Mr. Smith would be authorized to receive a one-time transition fill of at least a 30-day supply, and the plan should then follow up with a transition letter. Lastly, we would like to say that while Chapter 6 doesn't explicitly address a transition fill for expiring prior authorizations, we note that it may be a best practice for sponsors to provide a transition fill for at least certain PAs that are expiring in order to avoid interruptions in therapy. So moving on towards the end, section 30.4.10.1 is new in this version. This is new language for 2016, prescriber notification of transition fills. This was added because, as you can see in the new language in front of you, we feel the prescriber is in the best position to advise the beneficiary of the benefits or risks of switching to a different medication. The chapter ends with the appendices. As you see, Appendix A has been removed in this version. Appendix A was common acute care home infusion drugs. CMS is no longer maintaining this tool, and we have chosen to remove it in this version. However, new in 2016 is Appendix E, sample transition supply scenarios and eligibility. And we will walk through an example from this chart. So as an example, we cut a few rows, I believe the top 2 rows from the appendix above, and we'll walk through from left to right the top scenario and the bottom scenario. So starting on the top row, it is coverage year 1 and the beneficiary is with sponsor A, plan ABC, and their drug is on formulary. In coverage year 2, on the top row again, they stay with sponsor A, plan ABC, and their drug is still on formulary. Moving to the third column, the result, no, this beneficiary is not eligible for a transition supply. There was no change in formulary. Next, we'll do the bottom row. So again, it is coverage year 1. The beneficiary is with sponsor A, plan ABC, and their drug is on formulary. Middle column, coverage year 2, they stay with sponsor A, plan ABC, but now that drug is non-formulary. Moving to the third column, the result, yes, that beneficiary would be eligible for a transition supply. I will conclude my remarks here and turn it over to Bob Dombrowski for more information on formulary and utilization management. Thank you.
Thank you, Marie, and good afternoon. My name is Bob Dombrowski, and I work in the Division of Formulary and Benefits Operations here at CMS. Before I'd like to begin, I would like to let you know that I'm using some Star Wars references as well in my talk. I've included a few quotes from Yoda because I thought he was pretty inspirational and had a nice positive vibe going. And always, you learn a lot from Yoda quotes. I do want you to know that someone suggested that I use some Darth Vader quotes. While at times I think his quotes are really humorous, given the context of the situation that Darth Vader is in, I'll try to keep away from the dark side. So I certainly hope my talk keeps away from the dry side of things for you. Hope that this is a very informative talk for you. In the last week, we published a memo for on frequently asked questions for Part D formularies, and hopefully you've had a chance to look at it, and if you hadn't, that'd be a very good reference for you. Part of my talk today, too, we'll talk about the formulary reference file, and 2 years ago, we published a very good reference for you. I think it was on April 8th on frequently asked questions regarding the reference file. So we have 2 good publications that a lot of this talk will be based on. And the general topics that I'll be talking about today will be obviously providing some guidance on quantity limits. There have been changes over the past few years, so hopefully we can provide some clarification for you there. Also some questions that have surrounded formulary updates and how formularies can be updated. Reference file, there have been a number of questions on the reference file, and again, that reference from a couple of years ago will be very beneficial for you. And the last thing is some points and pointers on utilization management criteria updates. It would have been nice if I had that slide up first, but so these are the 4 topics I'm going to be talking about today. Quantity limits, formulary updates, reference file, and utilization management. So a general question, how the submission and review of quantity limits has changed. 2 years ago, I guess it was actually for 2016. It seems 2 years ago, but it was 2016. We've introduced the concept of a type 2 QL, quantity over time. So that was kind of brought about through industry having some questions with adjudication issues, particularly for drugs that were provided in timeframes that may be less than a 30-day supply or greater than a 30-day supply, something that didn't quite fit. So we introduced a type 2 QL. New for 2017, we've introduced this unit on a reference file, a quantity limit unit that we urge everyone to use when they're going over there in establishing their quantity limits. So while I'm talking about some things that changed, some things haven't changed. QLs, this has always been the case. For QLs that allowed the dispensing of a given drug up to the FDA maximum approved daily dose, they're not required to be submitted to CMS. So if a maximal dose of a drug is 80 milligrams and you have 80 milligrams, you can always apply safety edits for those doses exceeding 80 milligrams. You don't need to apply quantity limits. If you needed to apply quantity limits for dose optimization, that would be an area where you could apply quantity limits. Sponsors should submit quantity limits based on the daily dose over a 1 month period for nearly all drugs that are subject to a QL edit. These would be predominantly type 1 or daily dose quantity limits. So in reference to daily dose quantity limits, you would want to you could submit it one of two ways. One could be on a daily basis. Say that it's 4 tablets per day. You could submit 4 tablets per 1 day, or you could submit 120 tablets per 30 days. Either way you submit that QL, we interpret it as being a month's supply of medication. So it's important to know, though, if you submit it as 4 tablets per 1 day, that's what's going to be showing in Plan Find, and it will show on your marketing materials as well. And if the benefit for a drug is supposed to be in a monthly dose of medication, we don't allow plans to restrict it to less than that for a specific or unique drug if the drug is really intended to be given on a daily basis. Always two there are, no more, no less. That's a quote from Yoda. Somebody wanted me to impersonate Yoda, but I felt a little uncomfortable. I don't know how good it would have gone over. So, again, type 1 QLs are based on daily dose, and the majority of QLs are submitted as type 1. And actually, the introduction of type 2, again, has been for sponsors who've had issues with doses that, or quantities that are other than a daily dose. And some of these have been migraine medicines that aren't given on a daily basis. Type 2 QLs should rarely be used. If you've not had any problems adjudicating as a type 1 QL, you can continue to adjudicate your QLs and submit your QLs as a type 1 QL. The use of type 2 QLs will be subject to review and approval because some drugs are given on a daily basis, and a type 2 QL would not really be, reflective of something that's given on a daily basis. So new for 2017, sponsors should use this QL unit as a basis to submit their QLs, and it's on the reference file. The reason why we did this is because there was some confusion for sponsors, particularly with unique dosage forms like reconstituted vials and certain inhalers that weren't fitting the submission type that we had on our reference file for grams and mLs. In certain syringes. So this is kind of a nice way that we can both communicate in the same way. And the designations that we're using are based on the NCPD billing unit standard logic. And sometimes that can be kind of confusing in the sense that something could go either as an ml, something in the category of each could be either an ml or it could be each. And you'd have to look at the NCPD billing unit standard for the definition to see what that unique quantity or drug, how that should be submitted. Okay, this is a first question. Are party sponsors prohibited from making changes to their formularies between the summer update window and the beginning of the plan year? I'm liking what I'm seeing here. There was, at first it was 150%, but okay. Well, I think we have that. We got that. This is something that you're not prohibited from making changes to your formulary between the summer update window and the beginning of the plan year. So here's some good Yoda quotes that I think are kind of relevant to formulary updates. Difficult to see, always in motion is the future. And obviously this plays out with all the different new drugs and things that are always coming, and actually policies and things that are always changing. Always pass on what you've learned. We understand that there are lots of new people who come on to organizations even within CMS, and we share our expertise and knowledge, and we pass on what we know. And many truths that we cling to depend on our point of view. And as a result, we've tried to publish some frequently asked questions that you've asked to clarify some of these, so that there's more open communicative process, so that you can see where we're coming from as well. So the summer formulary updates prior to the start of the plan year. Summer limited update window is the final opportunity to submit negative formulary changes prior to the start of the plan year. And these would be maintenance changes when new generics are added to the FRF. So this would happen usually at the end of July, beginning of August. Right now we have it pretty much set for the end of July. So these are opportunities for you to take a branded product off the formulary and put in place a generic on formulary. So this is specifically for talking about negative changes. Formulary updates prior to the start of the year for enhancements, these can be like adding newly approved drugs. These can be added at any time, including before the start of the plan year. Marketing materials must be updated. So let the public know that these are drugs that you're marketing and that you have on your formulary, even though it wasn't what you initially had submitted to us in July. Changes must be reflected in the first available HPMS submission, and changes will not be reflected in Medicare Plan Finder until the changes made in HPMS. So until we see it, it's not going to be reflected in Plan Finder. So a couple of questions. When can plans submit negative formulary change requests, and how long does it take to approve an NCR? Plans can submit NCRs basically from January through July. They may opt to notify affected enrollees and other required parties that they, at the same time they notify CMS. So you can submit this change and at the same time notify beneficiaries, but just as a caution, just ensure that the change is consistent with CMS requirements in order to avoid rescinding or sending change notices. Brand changes may be requested before a newly approved generic is added to the FRF. So if you know a generic that has come out, you can actually submit this change. However, and it doesn't have to be on the FRF yet. However, that change cannot be implemented until the offsetting generic is added to the formulary. For 2016, CMS currently approves maintenance changes. Actually, it's around maybe a little over 12 days right now. For 2015, we put out in our frequently asked questions, it's about 15 days for maintenance and a little over a month, about 37 days for non-maintenance requests. How long does it take for a drug to be added to the FRF? This is a kind of complicated, not a direct answer I can provide to you for this. One of the most common questions we receive both from plans and advocates and even colleagues is when will this drug appear on the reference file? Unfortunately, we can't provide the exact date because this time varies and is usually not within our control. Our colleagues at FDA approve the drug, and there's typically some lag time between approval and the launch date. To create the FRF each month, we use a number of data sets, including the FDA's NSDE file, RxNorm downloads, and NDC databases. Once the drug is available in these data sets and is on the market, we evaluate it for the FRF. If we determine that it could meet the definition of a Part D drug, it will be added to the FRF depending on when the drug appeared in the data set and when it's added. On the left side of the diagram, as you see, while we're going through these iterations and decisions, sponsors are doing the same. So the P&T committee can review at any time, even earlier than the market launch date, once they know something's available. But the review should be done within 90 days of market availability, and a decision made with 180 days for non-protected class drugs and 90 days for protected class drugs. Okay, can plans cover drugs that are not on the FRF? You know, when these are yes and no questions and you've seen the 50%, yeah. Okay. Okay. All right. Well, I think the majority of you have gotten that. Yes, you can cover drugs that are not on the formulary reference file. Can utilization management be applied to drugs that are on a plan's formulary but not on the FRF? Okay. All right. Again, I think everybody gets that pretty much. You can have utilization management on a plan's formulary. So plans can add drugs to their formulary that are not on the FRF, such as drugs that are new to market. may be applied to these drugs. Additions can adjudicate at the point of sale immediately and must be reflected in updates to marketing materials. Formulary additions should be submitted via HPMS as soon as they appear on the FRF. An FRF add request must be submitted to CMS for covered drugs that are not yet on the reference file. So once you've added a drug that you know is not on the reference file, it's nice to let us know, hey, we're covering this, should we consider it to be on the reference file? If is required, the edits and criteria will be reviewed upon HPMS submission, and that may require modification prior to CMS approval. Okay. Can or safety edits be applied to drugs that are non-formulary? PA, STEP, or QLs within the FDA label dosing guidelines must not be applied to drugs not on the formulary. Non-formulary drugs are subject to general formulary exception requirements. However, safety edits such as maximum dose, limitations, cumulative MED may be applied to non-formulary drugs. So some of the safety edits that we talked about before certainly can be applied. Is a beneficiary who receives a transition fill of a protected class drug that has a PA or STEP requirement exempt from those requirements for subsequent fills? Okay. So, okay. Well, this would be a question that I think we needed maybe a little clarification. If a sponsor allows an initial fill of a protected class drug, it cannot determine at the point of sale that an enrollee is not currently taking the drug during transition, the sponsor shall treat such enrollees as currently taking the drug. Therefore, any protected class PA or STEP requirements or new starts are no longer applicable after the first fill has been provided. Can plans routinely update criteria? And do criteria updates require CMS approval? Existing PA or STEP criteria should only require updates in rare and extraordinary circumstances. Sponsors should perform necessary QA checks in advance of HPM submission in order to avoid having an update during the plan year. Criteria may be updated in a manner to allow inclusion of additional drugs without the need for subsequent criteria updates. We put out in January a memo for utilization management. updates. Obviously, removal of a restriction or addition of drugs to existing criteria are kind of enhancements. We were having issues with altered templates and folks just submitting changes for grammatical errors, which we really don't want to have to review. One of the things for hepatitis C, the guidelines have come out in the last 2 years, have increased from about 48 pages to 227 pages. And I think that in the market, there's been a lot of new products that have been entering the market, and things are in a constant flux. Often the guidelines have been updated at least a couple times per year, and we're all in a catch-up period of trying to have our criteria in sync. So we suggest that for hepatitis C criteria, maybe use a default, like criteria will be applied consistent with current AASLD guidance rather than restating information that's already contained within the guideline. It's hard. There are a lot of mistakes that are made and things keep changing with that guidance. So with that, I would like to say may the force be with you, and a friend wanted me to share this with you.
Remember, the force will be with you.
So for questions and resources, you can contact regarding Chapter 6, the Part D policy at cms.hhs.gov, and for the formularies, Part D formularies at cms.hhs.gov. And I don't think we have much time for questions, or? Okay. All right, thank you.
Okay, we do not have time for questions right now. However, we will have time at the end of the day to address questions to both Marie and Bob. So thank you very much. We are going to evaluate this session. So go ahead and go to your phones or your tablets, computers, and enter A and follow the instructions. If you do have questions for them, please go ahead and send them into the SurveyMonkey link, and we will address those later. Okay, here to provide participants with an overview of strategies. To help reduce inappropriate utilization of opioids from the Medicare Drug Benefit and C&D Data Group, please help me welcome Anna Polk and Diane McNally.
Thank you, Stacy. We were joking that she was going to say Anna before the presentation, so good job. Hello and good afternoon. My name is Anna Polk. I'm a pharmacist in the Division of Formulary and Benefit Operations. Diane McNally and I are going to be talking to you today about effective strategies to address the overutilization of opioids in Part D. And I apologize, I don't have any Star Wars jokes for this session, so unfortunately. To begin, I'm going to provide a brief overview of the CMS policy development in this area, and then discuss the levels for improving drug utilization review controls in Part D, and then show the various strategies that sponsors have used to date. Afterward, I'm going to turn it over to Diane, who's going to talk about the impact of this policy and also what's on the horizon. The opioid epidemic in this country has become a huge threat to public health, especially as drug overdose deaths in the United States hit record numbers in 2014. From 2000 to 2014, nearly 500,000 people died from drug overdose. This was not simply the result of illicit drug use either. At least half of these deaths involved a prescription opioid. In fact, since 1999, the amount of prescription opioids sold in the United States has quadrupled. I'm sure many of you here today have been prescribed an opioid at some point, and many of you may even know someone who's struggled with addiction. And you've seen the devastating effect this has not only on the individual, but their loved ones and society as a whole. So it's a huge problem, and it's one that's not going away without a dedicated multifactorial approach. Here at CMS, we take this incredibly seriously, but we can't solve the problem alone. As Sean stressed this morning, we need to work collaboratively if we are going to make any kind of meaningful impact. And we've got a polling question for you. In a single day, how many Americans die from an opioid overdose? And so we've got A, 13, B, 54, C, 78, or D, 115. And as you're making your selections, keep in mind that a similar figure for motor vehicle deaths is 96 per day. And it looks like the most popular answer is D, which luckily is not the correct answer, but it is C, 78. According to the CDC, 78 Americans die every single day from an opioid overdose. So I know that's a really grim introduction, but I wanted to frame this talk in terms of why we're putting out all this policy and why we continue to talk to you about this. And so what have we done to date? With the final 2013 call letter released in April of 2012, CMS provided comprehensive policy focused on medication safety with a goal to reduce overutilization of opioids while maintaining access to those in need. Further guidance was provided in September of 2012 to clarify the limitations and expectations, and then on 1/1/2013, plans were expected to implement several levels of improved formulary management. And what exactly did those 3 levels entail? Well, very briefly, level 1 is referred to as improved use of concurrent claim edits. We also commonly refer to these as safety edits or safety controls. Level 2 involves the use of formulary management strategies, so things like prior authorization and quantity limits. I'm going to be going into detail on these 2 levels and discuss the strategies that we've seen employed. And then Diane's going to talk to you more about level 3, which is the improved retrospective DUR programming and case management. So let's talk about level 1 in a bit of detail. This is our concurrent claims or safety edits. And please note that safety edits do not need to be submitted for CMS review and approval, as Marie actually outlined in the previous section. Safety edits could involve point-of-sale edits to prevent early refills or therapeutic duplication. They can also be used in accordance with the FDA-approved label to ensure drugs are used appropriately in terms of age and gender, and to make sure that the dose is appropriate. If a drug has an FDA maximum dose, a safety edit quantity limit can be set at this level. One other type of safety edit that's particularly relevant to today's talk is point-of-sale edits take into account the cumulative dose of all opioids being prescribed. We often refer to this type of edit as the cumulative morphine equivalent dose opioid point-of-sale edit. So I'm going to say MED and POS edit frequently on the next few slides so that I don't have to try to get out that whole phrase. But just keep in mind that's what we're referring to. MED is the morphine equivalent dose. So this type of edit was introduced by CMS in the 2014 call letter, where we strongly encouraged sponsors to develop the ability to implement a plan-level POS edit based upon cumulative MED across the opioid class. We did receive several questions and comments, but we didn't receive a complete policy. As you can see, for 2015, we did receive a handful of policies, but still for the minority of formularies. And then in the 2016 call letter, CMS continued to urge sponsors to implement at least a soft opioid MED edit while building the capacity for a more sophisticated edit. With this, we received an increased number of policies, but it was still not to the degree we would have liked. It was still only about a quarter. And as such, for 2017, we are setting the expectation that all sponsors implement a cumulative MED edit. We are not setting this requirement without experience, however. When the cumulative MED POS pilot when the edit was first announced, there were several commenters who felt that such edits were premature due to their complexity. So in order to test this, a pilot project was commenced in 2015 to assess the feasibility and impact of these types of edits. The pilot project included a soft edit where the pharmacist is able to override the edit at the point of sale using an appropriate NCPDP code. This was set at a daily MED of 100 milligrams, which had to occur for at least 60 days. There were also requirements for the number of prescribers and pharmacies. There was another sponsor who chose to implement a hard edit, which was set at a higher daily MED of 200 milligrams. And this required beneficiaries to request a coverage determination in order for the claims to process. Both edits did include various exclusions for things such as cancer diagnosis, those beneficiaries receiving hospice care, and beneficiaries who had already undergone a determination of medical necessity. So what we learned through this process was that sponsors were able to successfully implement both types of edits to address cumulative opioid use. And this was accomplished with minimal impact in terms of access, which is indicated by a lack of any formal complaints throughout the pilot. One plan even used questions from beneficiaries as an opportunity to educate them on the risks associated with opioid use. The participating sponsors felt that their edits were effective. One reported that 19% of beneficiaries receiving an edit did have a change in their opioid regimen moving forward. It should be acknowledged that these successes were the result of careful planning. Sponsors must do a careful analysis of their population and keep these findings in mind when developing their specific program. And it should also be noted that it did take some time to gain pharmacy and prescriber acceptance of the program. It's critical to notify the pharmacy and provider network in advance of implementation. So prior to implementing programs for 1/1/2017, it would certainly be advisable to do proactive outreach to those beneficiaries likely to be impacted. And also keep in mind that this will probably need reinforcement. In order to minimize false positives, the participating sponsors stressed how important it was to include exclusions. As mentioned before, the exclusions included in the pilot were cancer diagnosis and hospice enrollment, as well as prior determination of medical necessity. So this could have been through the coverage determination process, prior authorization, it could have been through case management, or also the appeals process. Even with these exceptions, however, about 10% of the coverage determinations that they saw did still have a cancer diagnosis associated. Other things to consider when developing a program is to include reasonable allowances for overlapping dispensing dates. And you can also include criterion for number of prescribers or pharmacies. All of these features will impact the outcomes of the program. And so with this experience in mind and these lessons learned, for 2017, we expect all sponsors to implement a cumulative MED edit. Pharmacy and therapeutics committees should look to their unique experience of opioid overutilization in their respective Part D plans when developing the specifications for their cumulative MED edits. We recommend that when a soft edit is used, the threshold should be set no lower than 90 milligrams MED, and when a hard edit is used, the threshold should be set no lower than 200 milligrams MED. We do expect sponsors to apply specifications to minimize false positives, as previously discussed. And if the sponsors do decide to include a provider count criterion, we do recommend that 2 prescribers of the active opioid prescription be set as the threshold at a minimum. I'd like to point out that we expect sponsors to exclude those buprenorphine products indicated for the treatment of opioid use disorder, so that beneficiaries are not denied access to these critical medications. With that being said, sponsors may choose to implement an edit for the concurrent dispensing of an opioid with buprenorphine for medication-assisted treatment, so long as they have the technical capability to only reject the other opioid and not the buprenorphine claim. So I'll touch briefly on the technical details for submitting the cumulative MED opioid POS Edit Program specifications to CMS, but please keep in mind that additional details will be forthcoming. So when you're preparing your formulary files for submission prior to the June 6, 2016 deadline, please keep in mind that if the only quantity restriction being applied is the cumulative MED edit, quantity limit does not need to be reflected on the HPMS submission. Also keep in mind that the edit is expected to be applied across the entire opioid class. And since it's considered a safety edit, it can be applied regardless of formulary status. In other words, each individual opioid does not need to be included on the formulary in order to be included in the edit. In order to allow some more time to fully develop and test these specifications, we're giving Part D sponsors until September 1st, 2016 to submit their information. This information will include documentation on the type of edit being used, hard or soft, the level of MED, any exclusion criteria, and other screening information. A template will be provided to sponsors at a later date that will provide more details. So we'll move now to level 2, which is the improved use of formulary management designs. So this includes quantity limits in those instances where there is no clear FDA maximum dose, which is where most of the opioids fall, as well as quantity limits set below the FDA maximum dose. It also includes prior authorization and step therapy criteria. So before we get into the levels and the strategies that we see used, I just want to provide a bit of background on the Part D formulary review process. So much of the data that you will see on the upcoming slides is pulled from HPMS, the Health Plan Management System, which is the system through which formularies are submitted and reviewed. Submissions are based on RX CUIs, which are adopted from the National Library of Medicine's RX norm system. Each RX CUI represents a distinct brand name, generic name, strength, route of administration, and dosage form. And when submitting formularies via HPMS, each RX CUI has to be flagged with all applicable quantity limits, PA, and STEP. As such, we can go back and look across all of the submitted formularies and see how often a certain type of was used for an individual drug or for a class of drugs. And also keep in mind when we're working through the next few slides that we're going to be looking at the formulary level or formulary ID level, but an individual formulary could be linked to multiple plans. And so before we get into all of the details, I wanted to see what you think. Since CMS first released opioid guidance in 2012, up to the present, what do you think is the % increase in the use of quantity limits on formulary opioids? So we'll be looking at those formularies submitted just prior to this guidance being released to those most recently submitted in 2016. And it looks like folks are split between 51% and 98%. It's actually 128%. We've seen a huge increase in the use of quantity limits on the opioid class. So this slide is showing that to you in graph form. In 2012, looking across the opioids present on all Part D formularies, quantity limits were applied 37.7% of the time. After CMS introduced the DUR requirements for the opioid class, which you can see represented by the red arrow there, we saw that increase to 64% for 2013. This has continued to climb steadily up to 86.1% on the most recent submission, which was for 2016. And this table shows you which individual drugs had the largest change in quantity limit rates from 2012 to 2016. You can see the top agents were oxycodone products, both individual and combinations with acetaminophen, where the rates changed from between 10 and 15% in 2012 all the way up to 83 to 93% in 2016. And you can see a few other agents that were the other biggest changes. So next we'll talk about prior authorization. And you can see that compared with quantity limits, it's used much less frequently on the opioid class, whereas before we were in the 80% range, now here we're just in the teens. You can also see that red arrow, the introduction of this opioid policy, didn't really seem to have much of an effect. We did see a small increase in the use of PA in 2015, but it's likely that this correlated more with the section of the 2015 call letter that talked about the appropriate use of PA. this section talked about the transmucosal immediate release fentanyl products specifically, and so we did see a small increase. And again, drilling down to the individual agents, you can see those turf products, the fentanyl products, were those that had some of the biggest changes. The other agents with the biggest changes were actually either high-risk medications themselves or opioids combined with medications that are considered high risk in the elderly. So whereas it seems like the change in quantity limits was really driven by this opioid policy, the changes for PA rates seem to be driven by other policy changes. And then the last piece of the formulary utilization management strategies is step therapy. And you can see that this is used even less often than prior authorization. Now we're down in the 1% to 2% range. And it doesn't seem that the opioid policy had much of an effect on this. And so with that, I hope you have a better understanding of what folks are doing on their formularies in response to this policy. And I will turn it over to Diane to get into level 3.
Thanks, Anna. I don't know if you all want to get up and stretch. I know you've been sitting a long time. Feel free to. So again, my name is Diane McNally, and I'm from the Division of Clinical and Operational Performance. And my portion of the presentation will discuss the Level 3 drug use review tools, including the beneficiary level opioid. Oops, hold on. The beneficiary level Marx opioid POS edits. I will also discuss the overutilization monitoring system. And then I'll get into some details on the Part D sponsor compliance outreach we performed in 2015, along with some key findings from the outreach and other DUR activities that have been going on for the past couple of years. And then I will then end with a discussion of the policy and guidance provided in the 2017 call letter. In the 2013 call letter, as Anna talked about before, CMS expressed our concerns that plans could be doing more to address the overutilization of opioids. Anna previously described both Level 1 and 2 DUR tools, and as her analysis showed, most formularies have implemented these tools to some extent. The final DUR tool is the Level 3 controls, or retrospective DUR with case management. Our guidance suggests that these programs should include the retrospective DUR criteria to identify patterns of inappropriate drug use. This is different than concurrent DUR. Concurrent DUR identifies overutilization at a single point in time, where retrospective DUR can identify inappropriate patterns over longer periods of time that may not be identified at point of sale. Once overutilization use is identified, case management is employed, which may include a review of PDE claims and outreach to prescribers, providers, and beneficiaries to determine if the drug use is medically necessary. The final step of Level 3 is to assess whether implementation of a beneficiary level point of sale, which is different than a formulary point of sale edit, is necessary to control this individual's opioid use. This is now discuss the beneficiary level opioid POS edit determination process, which is pretty much driven by the prescriber's response to the Part D sponsor's outreach. If a plan is able to directly communicate with the prescriber, CMS expects the discussion of the complete opioid regimen among all prescribers, not just a certification of what the prescriber wrote. The discussion may go beyond the total morphine equivalent dose, or MED, to address the opioids prescribed, including dosage forms, quantities, as well as other concurrent drugs. And as we all know, benzodiazepine and the use of opioids become a very serious problem and is highly correlated with overdose. If there are multiple practices involved, the discussion should also attempt to identify a single prescriber willing to manage the patient's pain therapy. What we don't want to see and hope not to see is that the patient is totally discharged from all practices, and then they end up seeking care from the emergency room. So we hope plans are trying to help these beneficiaries get coordination of care. Plans should continue to monitor their beneficiaries' opioid use, also to confirm that decisions were implemented. If the consensus is that a beneficiary-level POS edit is necessary to control the patient's opioid use, then the plan needs to notify the beneficiary and prescribers of the action and agreed-upon opioid regimen, along with CMS. One more thing. Finally, if none of the opioid prescribers respond to the plan's outreach, the plan should monitor use to see if the use improves, because sometimes just contacting the prescriber will change the beneficiary's use or the prescribing. But it should only be monitored for a short period of time. And if the use doesn't improve, then with input from their P&T committee, the plan should implement a POS edit that either limits the opioid use or denies coverage for any opioid. If the overutilization does not improve, just monitoring opioid use is not sufficient. The beneficiary level opioid POS edit database. Okay, now I'm old-fashioned, I'm just no polling. How many are familiar with the opioid POS edit Marx Database? A few. I guess everybody online, on the phone knows it. Okay. Originally, when we implemented this policy, plans had to submit to us the letter after they contacted the beneficiary. But now, on February 8, 2014, the POS Edit database within Marx went live. So plans can now send the opioid POS Edit information electronically to Marx or enter the information through a user interface. Yes, no more emails, well, at least for me. However, plans still need to send the letter to their account managers, their regional account manager. The system also assists plans by alerting any new plans if a new enrollee had an active POS Edit during his or her prior enrollment. Prior plans no longer need to alert new plans if any of their enrollees have an active POS Edit, as long as the POS Edit information is submitted to Marx prior to a beneficiary disenrolling. Another advantage of the Marx system is that, and for entering your POS Edit into Marx, is if the beneficiary is subsequently identified in OMS, if the beneficiary is found in the POS Edit database, we will suppress them from future reports. So the process for submitting a beneficiary-level opioid POS edit to Marx. Once the beneficiary is notified of the edit by mail, the plan is expected to submit the POS edit information into Marx. We clarified in the 2017 call letter that the edit information should be submitted within 7 business days. And this is important in case the beneficiary disenrolls, then the new plan won't know that the person had a POS edit prior. The POS edit information includes, as listed on the slide, demographic information, the HICN, the notification date, the POS edit code, which is either PS1, meaning no opioids are covered, or PS2, when limited opioids are covered. Plans are also expected to submit to Marx any follow-up decisions, such as a change in the POS edit from PS1 to PS2, adding an implementation date or a termination date if applicable. Again, the information should be submitted within 7 business days of that event. Also, please be careful that the same notification date is used when submitting updated beneficiary POS edit information. I have found in the database for the same contract, same beneficiary, multiple notification dates with the same POS edit. What we suggest is to reduce errors is to use the user interface. That way you can see what information was entered prior and you'll get a real-time response for the data you enter. Once the POS edit information is entered into Marx and the edit is not terminated, if the beneficiary disenrolls, the new plan will be notified of an active POS edit on the DTRR, or the Daily Transaction Reply Report, with the TRC, Transaction Report Code, of 322. The new contract is expected then to contact the prior plan's overutilization contact person to request or discuss the associated POS edit documentation. And guidance is provided in the final 2013 call letter regarding that. If the new plan decides to continue the POS edit, it can implement the edit and send a notification letter to the beneficiary concurrently and waiving the 30-day notification requirement. So what has this policy impact been on so far? So as of April 6th, 188 Part D contracts have submitted POS edits for 2,564 unique beneficiaries since the implementation of the policy, which was January 1st of 2013. As you can see, the majority of the beneficiaries are under the age of 65 years, but only a very small percent of beneficiaries disenroll shortly following the POS edit notification, 3% within 30 days, and 6% within 60 days. And about 8% of beneficiaries with a POS edit switched plans, and the gaining plan continued the edit. So most plans don't continue the edit, and hopefully it's because use has decreased to an appropriate level. Currently, 57% of the notified beneficiaries have an active POS edit, and that is associated with 126 contracts, or about 17% of Part D contracts. Okay, another polling question. How many people are familiar with the overutilization monitoring system? All right, a few more, good. This system was implemented in July of 2013, and its purpose is to assure that sponsors are compliant with CMS's overutilization policy. Each calendar year quarter, the OMS generates reports for Part D sponsors, identifying their beneficiaries that met CMS's APAP or opioid overutilization criteria during the prior 12 months. So, for example, the April report that just went out last week evaluated data from April 1st of 2015 through March 31st of 2016. Once the reports are released, sponsors have 30 days to submit the outcome of their review for each case identified in by CMS in the OMS reports. Plans can also submit through OMS the outcome of cases that were internally identified by the plan outside of the OMS criteria. These cases may be excluded from future OMS reports if applicable. And here is the criteria, which I'm not going to read, but in the OMS there are 3 types of cases: the APAP overutilizers, opioid overutilizers, and CPI referrals. We also include cases that were referred to the Medicare Center for Program Integrity that are not under investigation by law enforcement. These cases are then recycled back to the plans for further evaluation and potential case management. So, what's happened to date? So, what impact have we observed since CMS released its policy on improving drug utilization review controls in Part D? As reported in the 2017 call letter, overall, Part D has seen a significant drop in the number of beneficiaries identified as APAP and opioid overutilizers. This slide illustrates the change observed in the opioid use. In particular, the Part D program has experienced a 47% drop in potential opioid overutilizers from 2011, which was prior to the policy release, through 2015. An even larger decrease of 57% was observed in the percent of opioid users identified as overutilizers or outliers. This decrease occurred while the percent of opioid ever users had one or more claim, remained constant, even as the number of Medicare enrollees increased, suggesting that the decrease in outliers is not due to an increase in enrollment or a decrease in the number of opioid users. At this time, we would like to thank Part D plans for your hard work in helping us to reduce opioid overuse in Medicare. So give yourself a pat on the back. Okay, now, even though we have seen a decrease in outliers, in 2014, we were very concerned that a majority of the responses submitted to the overutilization monitoring system by Part D plans were, does not meet internal criteria, and overutilization resolved. And we would get that repeatedly for the same Benny, which didn't make a whole lot of sense. So we conducted an outreach program in May of 2015 for two goals. Assess sponsors' compliance with CMS opioid overutilization guidance, and determine if revisions in the policy guidance and/or the overutilization criteria was needed. We selected 8 parent organizations from the October 2014 OMS cycle who had high rates of specific or repeat responses, and those who had no or low rates of beneficiary level POS edit submissions. The outreach asked the parent organization to answer a general question regarding their internal criteria, an overutilization policy, and specific questions regarding individual beneficiaries identified in OMS. And on the slide are those questions. In general, what are your internal criteria for identifying potential opioid overutilization? More specifically, which criteria were not met for the tickets provided, and please provide a detailed response. In conclusion, we found that most sponsors were compliant with CMS guidelines. And we also were able to identify opportunities to modify the opioid overutilization criteria in an effort to reduce false positives. Some of the reasons that plans gave why the beneficiary did not meet internal criteria or the overutilization was resolved were the following. The prescriber or the pharmacy count was not met. Some of the sponsors were able to identify physicians that were in the same practice. CMS will be working on that in the future, but at this time, we have to use the MPI, which is unique per prescriber. And some plans also would group chain pharmacies and count them as a single pharmacy. The second one was situational acute events. The patient would go have a dental procedure or a surgery, and that might increase the number of prescribers and even the dose. Plans also considered consistent opioid regimens with no evidence of early refills as appropriate, and the overutilization decreased during more recent months. Since the OMS criteria looks back at 12 months of PDE data, use that occurred earlier in the year would be flagged despite recent use that was below the criteria threshold. Potential lack of POS edit. Plans that lacked a POS edit felt that direct communication with prescribers and follow-up monitoring was sufficient and would often impact the members' opioid use. In addition, sometimes the high number of prescribers was due to a lack of coordination of care, and if a prescriber was willing to coordinate care, there was no reason to implement a POS edit. So based on the outreach findings, CMS sees its next steps to analyze options to modify the opioid criteria, including shortening the review period and averaging the opioid MED with consideration of the new CDC guidelines for treatment of non-cancer pain. Our goal is to report any potential opioid criteria changes in the 2018 call letter to allow for comment. So, our overutilization policy that was reported in the 2017 call letter. So given the changes observed in the level 1 and 2 DUR formulary analysis and decreases observed in the number and percent of opioid and APAP overutilizers, we reported the following policy: opioid use monitoring. As stated before, we will investigate the OMS opioid overutilization criteria modifications and changes in how prescribers are identified. Within OMS, we have added the contract level opioid high daily dose rate, which is calculated as the number of opioid days greater than 120 milligram MED per 1,000 opioid days prescribed. For acetaminophen, we will continue to monitor, and if you haven't opened your April OMS packages released last week, good news, APAP reports are gone. However, we did move the APAP monitoring to the patient safety reports in the form of a contract level APAP high daily dose calculated rate similar to opioids, which is the number of APAP days greater than 4 grams per 1,000 APAP days prescribed. And in 2017, we see the APAP rate will probably be included in the patient safety outlier report. So if your plan is an outlier on the number of days on this rate, then you'll show up in that report. Additional priorities. Despite the overall positive results, we need to remain diligent in improving opioid use. So we are shifting from a retrospective DUR focus to concurrent DUR tools with the implementation of either a soft or hard POS cumulative MED edit, which Anna has previously described. In fact, one of the contractors who implemented a hard edit observed a reduction in cases referred for case management. The soft opioid POS claim edit following the initiation of buprenorphine for opioid use disorder, as long as buprenorphine is not denied, again, as Anna mentioned before. For submitting and updating POS edits to Marx, we clarified in the call letter that timely means 7 business days. So please, I hope that is not too burdensome. We remind plans that formulary structures should not impede medication-assisted treatment for opioid use disorders. And finally, sponsors should review their utilization management process to ensure that methadone is not the preferred opioid for pain management. Methadone is frequently associated with overdose, and the CDC guidelines now recommend that methadone only be prescribed by a pain specialist. So, in conclusion, Part D plans should congratulate yourselves. Improved opioid and APAP utilization controls are moving opioid overutilization rates in the right direction, and we thank you. Cumulative opioid MED POS edits with exclusions are possible and are effective in reducing opioid use. And as Anna mentioned before, it's important to query your database, query your beneficiaries, and see how best to implement that. CMS is pleased that the majority of studied Part D parent organizations are compliant with CMS opioid criteria. And also, sponsors use beneficiary-level opioid POS edits sparingly following case management. Whether the current level is appropriate will require additional analysis, but overall, we are seeing a decline in opioid overutilizers based on this current metric. Finally, I want to leave you with some additional resource links and the CMS mailboxes that you can use for questions. So the first link is the improving drug utilization controls in Part D. Anything that has to do, any memos, the call letters, or reports that have to do with Marx, the overutilization monitoring system, and DUR tools, retrospective DUR tools, can be found on this website. So go there first. Next is the link to the Plan Communication User Guide, and that provides detailed instructions how to submit a beneficiary-level opioid POS edit to Marx. The next link is the Formulary Guidance. Guess what that's for? Formulary. And the final link is the link to CDC's new guidelines for general practitioners on prescribing opioids for the treatment of chronic non-cancer pain. And If you have any specific questions, you can submit them to these mailbox. Again, the first one is for formulary. The Part D OM is for Marx questions, anything that has to do with opioid overutilization. And for patient safety, if you have any questions on OMS or your patient safety packages, you can email the Patient Safety Acumen website. Thank you all for your attention, and I guess we have any questions.
Okay, unfortunately, we are out of time right now for questions, but Anna and Diane will be back at the end of the day for the open Q&A session, so I would like to thank them for their strategies to improve medication use. Okay, here we are again. If you would like to evaluate session 5, go ahead and either text in A or put that in the Poll EV website. And look at that, it is time for an afternoon break. We will take a 15-minute break and we will return here promptly at 2:30. And remember, if you have any questions, go ahead and send them in through that SurveyMonkey link, and we will address them either during the sessions or at the end in the open Q&A session. Thank you.
Yeah, she's coming. She had to go pick up her daughter. She usually gets here at 7 and leaves at 3 because of her daughter's school lets out. So she went to pull her out early so she could stay for the whole.
Do we need to show the name? I don't know for the camera purposes.
Probably. Where is the camera?
I think it's that one over there. Start rolling. It's already contagious.
I know. It's terrible.
I just hope that everybody watching it on the internet sees the break slide and not the four of us just sitting up here making small talk. Incredibly awkward. Yeah, because I know somebody back at the office is taping it. It would just be really uncomfortable. Wow.
Yeah, it's amazing how people, I remember just a few years ago, everybody came to these live, and now it's all.
There was a lot more.
Yeah, now everybody goes and watches. Which is great.
Where's he go?
You have the Medicare.
Say he's coming back, right?
Yes, that's the role I
That's
have.
not the time for Lee to make a quick
And
exit.
how is everything going? You guys are in a similar boat of us, going through some DOJ reviews and hopefully getting some acquisition work underway.
We're keeping very busy with that, I'm sure you are.
Yes.
Yeah.
Yeah. And you just keep your fingers crossed that we still can get through AEP and everything else. It's not the second half of the year is going to be
Very good.
Yeah, I have too. We were sanctioned in 2009. It was tough. It's really tough. And all you're focused on is getting back to what I did not have to and then it's really tough.
We cover everything. Is a lot of your team here today?
Actually, I'm the only one here in person. Most of them are on the webcast.
Are yours all in the
Yes.
Yeah. Don't forget to close up. I've always seen you.
If I over-rehearsed. I was in my own office yesterday, just talking through it, and it took like 35 minutes. I was like, all right, we're back. Oh, hi, Linda. Lee Jenko, how are you?
Hey, Linda, Michael, good to see you. How are you?
Wait, Lucy's not going to come watch?
She had a choice of, I had to go get my daughter from
Yeah.
middle school.
You didn't drag her to this, did you?
Well, she had a choice. She could come to this or go sit in my office and play on my iPhone.
That was an easy
chose
choice.
Wi-Fi.
Yeah.
She asked me if I had Wi-Fi, and I said yes. So, let me turn off my things.
Nice.
How are you feeling? How's the perspective from this end?
I think good. Unless you have a surprise.
Please no surprises right now.
I'm really just sitting up here because they put me actually on the agenda. That's going to be cool. And then I didn't want to look like I didn't show up.
Yeah.
Yeah, we'll just be cool. It's a good message you're delivering, so that makes it easier.
I did just get notified by another sponsor that they're considering a PBM change.
Oh, really?
They asked, when do we have to let you know? I said, well, 60 days is the requirement. But really,
It's not enough.
you should just let us know now.
Yeah. Okay.
Yeah.
It's good to know.
You didn't say anything.
every time, right, every time I see this.
I always look at PDPs or pharmaceutical orders when I was at home. Yeah, there was a
Start? Want me to start? 100 buys one. Just checking.
Welcome back, everyone. We are going to get started. We have a couple panels yet today. So if you can please have a seat. And those of you in our viewing audience, thank you for hanging in there with us on the webcast. And thank you to those of you who are in the audience for being on time. Our next session is a panel of speakers from WellCare who will share key areas of focus relating to Part D that contributed to the overall success in moving from one pharmacy benefit manager, or PBM, to another. From CMS, I would like to introduce you to Ariane Spaccarelli, who will introduce the WellCare panel.
Hello, I'm Ariane Spaccarelli. It's my pleasure to introduce Michael Yount, Lee Jenko, and Laura Hungaville from WellCare. They've joined us today to discuss the lessons learned from transitioning PBMs for 2016. They will be discussing the strategies that they use to promote a smooth transition and to monitor the transition following January 1, as well as areas of opportunity to improve for future transitions. In the spring of 2015, WellCare notified CMS Central Office that they would be transitioning PBMs effective January 1st, 2016. This began a series of meetings and calls with CMS Central Office and regional staff regarding WellCare's planning for the transition. This early and frequent communication with CMS allowed us to share our experiences and lessons learned from other large migrations as WellCare planned for and implemented its transition strategy. From CMS's perspective, the early communication and collaboration with CMS was particularly important because it allowed us to work with WellCare to plan for and mitigate disruptions caused by changes in formularies and the pharmacy network. WellCare's representatives will discuss the strategies they use to prepare for formulary changes, minimize disruption to the network, and communicate with members and providers regarding the changes. WellCare's experience should be very helpful for sponsors contemplating a PBM transition. Their experiences and lessons learned can also be instructive for sponsors contemplating significant network, formulary, or systems changes, as many of the issues that WellCare dealt with also arise in those contexts. Their planning, communication, and mitigation strategies provide a useful model for any sponsor contemplating a major change in the administration of its Part D plan. So please help me in welcoming WellCare's representatives.
Thank you, Ariane. To start, we have a poll question, and I promise this is an easy one. It's just for the panel to gauge the audience and their experience. So you can see, A, I represent a sponsoring organization that includes Part D benefit. B, I represent a sponsoring organization that does not have a Part D benefit. C, I'm a key stakeholder in policy making and oversight of benefits, for example, CMS, CMS partner, or an advocacy group, or D, none of the above. Thank you. In 2014, WellCare had initiated an RFP process to begin searching for a pharmacy benefits manager. We had both our incumbent PBM as well as other PBMs respond to that request for proposal or RFP. And as a result of that process, WellCare had elected to change or transition PBMs beginning in benefit year 2016. This was a significant undertaking for not only the organization, but for also our outgoing PBM, as well as our incoming PBM, as 3.5 million members, both Medicaid and Medicare, would be impacted by this transition in PBMs. The goal of WellCare, its PBMs, as well as the agency, was to ensure that we had mitigated any risk to the beneficiaries and that we had a project plan initiated and implemented and maintained that would ensure that any harm to beneficiaries would be reduced, or in the event that there was missteps, it would be identified quickly and then remediated efficiently. Based upon the number of issues and based upon the number of members impacted, we believe that we had a successful PBM conversion. Lee and Laura will share with you some of those numbers and some of those results. The goal today, as Ariane had mentioned, is really threefold. One is to provide you all with some aspects of our work plan, some of what we worked on for nearly 11 months, both internal and external, with our PBM partners as well as with our CMS partners, as well as two, to discuss with you lessons learned. There were some issues, there were some missteps, and we think we learned from those, and we think you can too. And then third, and maybe this is most important, but to make ourselves available to you. One of the benefits that we had throughout the process was some conversations that we had with our peers who had recently undergone a PBM conversion. And those conversations were transparent and candid, and they were very helpful to WellCare and ultimately to our beneficiaries. As I had mentioned, there was a significant number of members that could be negatively impacted by this type of transition. WellCare had recognized that potential for a significant adverse impact very early on in the process, and we ensured that there was a focus that the beneficiary would receive his or her prescription or his or her therapy in a very timely manner so that there would be no adverse impact. In order to ensure that, we had a number of conversations, both internally, but also externally. We had, very early on, I believe it was June, reached out formally to CMS, both at the central office and with our regional account managers, and advised them that we would be transitioning to PBM, but more importantly, requested and received their partnership and collaboration through that transition period. In addition to our regional account managers, we had multiple conference calls with the central office staff, and we had calls in which it was not only WellCare representatives and our incoming PBM representatives, but also representatives from the central office and regional office staff. As we led off today's presentation, both Judith Flynn and Brenda Suter talked about collaboration with the regional office staff. I think this is an example of where collaboration not only benefits the agency as well as the plan, but ultimately benefits the member and the beneficiary. The discussions were transparent. The discussions were candid. WellCare had actually provided to the agency our work plan that included proposed member communications. And examples or drafts of those types of communications. In response, we received observations and insight from CMS, both at the regional office level and also at the central office level. Recommendations were made, or ideas were given to us that, quite frankly, we had not thought of. That dialogue was very productive, and again, I think it was a very key part to our overall success. In addition to the external communications that we had with our agency partners, we also had a very significant amount of internal communications. There were work groups established amongst the pharmacy team with nearly every representative department within WellCare. This was identified as a top 5 goal for the organization for 2015, and the focus was put on that. But just as importantly, there was a communication from the top. There was a communication from our CEO and from our executive leadership team that throughout this very long process, if there were any concerns, if there were any deficiencies, if a certain part of the project began to go off track, that the associates were encouraged to raise the concern, that the associates were encouraged to identify that there may be missteps so that we could timely remediate any issues that would come up. That type of transparency, not just external but internal, was also very key because it allowed us to have very transparent communications, but also allowed us to identify issues very quickly before we got too far down the road. So that governance or that accountability structure was key. We also had not only our executive leadership engaged, but we had the executive leadership of our incoming PBM engaged as well. And there were frequent conversations between those two groups. And we also had frequent updates that we had provided to our board of directors, both from a compliance risk standpoint, but also from a member risk and operational standpoint.
Hi, I'm Laura Hungeville, and I'm WellCare's Chief Pharmacy Officer. I'm just going to spend a few minutes talking to you about some of the mitigation strategies that we put in place, and then I'm going to turn it over to Lee, who's going to go into the details of our plan, which is probably what is most interesting. So that executive support that we had at both organizations really was key, and one of the challenges that we put forward was, all right, let's think about anything that could go wrong, and let's think of a mitigation strategy, or let's head something off before it happens. So we spent a lot of time evaluating all of the changes that were going to be happening to our members, and that happen to them, frankly, every year. You know, a formulary change, network changes, benefit design changes, and then having to show up with a new ID card causes enough confusion. We thought all of these things happening at one time, we want to try and think outside the box, and let's do some creative things. And that's where CMS gave us a lot of insight, and our reaching out to the peers as well as our PBM partner really helped us come up with some unique strategies. So some of the things that we did, we spent a lot of time with disruption analysis, looking at individuals' formulary utilization, looking at the pharmacies that they were getting their prescriptions at, and we spent a lot of effort reaching out to those pharmacies and then looking at the medications and see what can we do? What can we do to minimize this impact? And we made significant changes to our formulary in the fourth quarter in anticipation of the formulary we would have in 2016. This had some financial ramifications from that, so that's certainly something that you need to consider when you're thinking about making these big changes and the investment that you might need to make to really have a really smooth transition. We had emergency fill override processes in place. We have those, and we really beefed up our communication with our call center teams in the training to make sure that when they got a phone call and there was a beneficiary, a member at the pharmacy needing their medication, that they were going to be able to leave that drugstore with it. And so that included both overrides of formularies, and it also meant that overriding for pharmacies that aren't in the network, which is not something that's very common in the industry. And we were fortunate to have a PBM partner that helped us with that. And a very, very robust communication strategy, which Lee will spend a little bit more time on. We had numerous touches. I don't think that you can communicate enough. And we had some creative reaches to try and make sure that we were getting everyone's attention. But while this was mainly focused on the beneficiaries and the prescribers, we also spent a lot of time and effort communicating with pharmacies. We reached out to trade associations like NCPA. We talked to legislators in our markets. We talked to patient advocates, the SHIPs, and we reached out to business partners like the SPAPs. So we wanted everyone to understand what was happening, what it would mean to a beneficiary, and what they could help us answer beneficiaries' questions if they got them. And we also spent a lot of time with prior authorization as well, looking to see if there were just exceptions that we needed to make or help people transition going forward. They told me to be patient. And Michael talked a little bit about peer-to-peer. We did engage in dialogue with other health plans that had gone through conversions, and they were very helpful in sharing with us the things that they would have liked to have done differently along the way, and we learned from that. And we hope that we can offer that to the industry as well. So now to the details. I'll turn it over to Lee.
Thank you, Laura. So first, I want to touch on project planning. We announced our PBM conversion in February of 2015, and one of the first tasks for us was aligning on our critical dates. In order to do that, we had to identify our critical milestones, identification of the key risks, install an oversight process to this project plan, and ultimately we were able to accomplish an integrated project plan by May, which was just a short 3 months later. We had over 4,000 tasks, over 200 critical milestones that we put in place. The governance structure, Michael talked about the amount of different individuals across the organization. We had 19 different work streams across our company. That also included our new PBM that was involved in each of those work streams. Those teams met on at least a weekly basis, and we would get together every 2 weeks with the leads of each of those 19 work streams to go over project status, and we included other management level folks in those sessions to provide ready and timely updates to the organization. Additionally, we had executive engagement through steering committee meetings. We felt it was important to have an internal steering committee meeting among our own executives, but in addition to that, we had a joint executive meeting with our PBM and our executives at our health plan just to make sure the project was staying on track. One of the more beneficial aspects of the reporting process was a weekly readout. It was an executive summary that we had published for our leaders across the organization that provided line of sight into key issues, what the overall project health was at that given week. We looked at key decisions that were required. By promoting those key decisions, it allowed us to have more timely engagement with our executives and the key decision makers so that those items could be closed quickly and we could keep things moving along. as well as the identification of any work streams that perhaps had gone off track. They were in a yellow or a red status. Those were all called out specifically, along with the path to green. What would it take us to get back for that particular work stream to get back on track? Pre-deployment planning, we went through some exhaustive QA and testing, as one can imagine. I would just offer, when you're thinking about your test strategy with your PBM, we took a wealth of information from them and test strategies on what they recommended. We then looked at all of our risks that we had identified throughout the course of our project and put test strategies around each of those risks. And then we overlaid that with our own lessons learned from previous Part D annual changes. We completed an operational readiness assessment that took place in November and in December to get us ready. I liken it to a pilot that's making a pre-flight check, making sure all the switches are on, the plane's in good working order. We went through that process, and one of the exercises that I found most beneficial was going through catastrophic contingencies. So these are the worst case scenarios of what could possibly happen. And I can tell you we had 27 of them, and if any one of those 27 had not have planned out, we would be up here having a much different conversation with you today. So, but I bring that up because it was helpful for us in just talking through it and developing the mitigation of each of those critical contingency plans, because it forced us to look closer and just make sure that we had accounted for everything associated to those critical catastrophic contingencies. And then finally, from pre-deployment, we had engagement from an outside independent consultant came in and gave us a readiness review assessment in the month of December. Given the time frames, it was highly driven on process and just making sure that any key identification of risks had not gone unturned. Post-go-live monitoring. We looked at all the paid and rejected claims. The month of January, we had reviewed 3.5 million claims. We focused on transition, formulary, pharmacy network, of course, help desk, beneficiary calls, complaints. What I would call out here that was unique in that we worked closely with our operations team to really look at the CTMs and grievances that were coming in. We felt it was important not to develop a brand new process for that team, but we wanted to make sure our pharmacy SMEs and the folks that had been engaged in this project were on the front lines and looking at those individual cases as they were coming in. So we developed a reporting mechanism based on intake, where we were actually reviewing all of those CTMs and grievances on a daily basis, and we would have a team of experts that would go through and review so that we could quickly spot out any trends, any particular issues, and then and get ourselves directly engaged back with our operations counterparts in order to provide timely feedback and resolution. From the reporting perspective, the key performance indicators, the things we were looking at on a daily basis, we were actually developed a daily executive dashboard that we were producing, again, to much of the same folks in the project staff. And the daily dashboard had the key metrics around call center, pharmacy network, our coverage determinations. We had a number of formulary changes that we were closely monitoring. But one of the areas that was important to us, again, in transparency when we developed this, was having conversations with Ariane and Linda to really understand what does success look like together, and then what are the metrics that we're going to add and put into that. So that conversation proved very helpful for us in development of our dashboard, and what we looked at ultimately was the exact same view that we provided to CMS for our Medicare metrics. Now I'm going to talk about our communication strategies, which I think is probably the cornerstone of our conversion, the reason for success. You know, Ariane mentioned that perhaps you may have other conversions, system conversions, network changes. Maybe it's not a PBM conversion, but perhaps some of these things that we had incorporated in our plan might be beneficial to you. So we think about outbound calls or inbound calls. I won't go through all of these in great detail, but I do want to call out what I would consider key differentiators for us in our plan. From an outbound call perspective, we had all members that received an ID card. Across our enterprise, we had 3.5 million members that were disrupted by the fact that we were going through the conversion. So we used automated calls to these members to make sure they knew we sent you a new ID card. It has some very important information called 4Rx. Make sure you show up at your pharmacy in January and present that new ID card, as well as highlighting some of the key changes that we were going to be producing. We produced and developed some very scripted messaging for formulary and network. We targeted those members specifically with phone calls. And then here is, again, one of those key differentiators that I would like, and we're going to use this as a best practice, and that is we looked at every member that had ever filed a CTM in the last 2 years, and we overlaid that population of members with all of our formulary and network changes. And we created a specialized unit within our call center that made outbound calls to those members, understanding that it might be a little prickly conversation. We're calling to tell them that their drug may not be covered next year, their pharmacy may not be in the network, but that proved immensely valuable for us in having those proactive conversations with these members overlaid with all of our other communication plans. On the inbound call side, CSR training was very important. We wanted to make sure when agents were on the phone and having conversations that they were educated on all of the changes. We had, for all the members that were going to be impacted, and I keep referring to the amount of impact, we had about 1 in 4 members that were impacted by a formulary or a network change, so it was significant. We flagged in our core system that these members, the ones that were impacted, so that the CSR agent could actually identify that if they happen to be engaging with that member in a conversation. We also had IVR messages, everything from inbound IVR messages around ID cards, formulary changes, and then our pharmacy help desk, we had messaging around our new 4Rx information. Now, from a digital perspective, we put, Laura mentioned some of the additions we made into our formulary, and that's where we really tried to leverage that as an avenue to let members know that we had made some additions, positive changes that would help us mitigate the abrasion. So that information was on our provider and our member web portals. On a written communication perspective, we had a targeted network disruption letter. So this letter was developed, told the member exactly what pharmacy they were using, that they would no longer be able to use that pharmacy, but which pharmacies were in the geographic area. And we had 5 alternates available for the members on this letter. On formulary changes, very similar approach. We identified the target drug that was being either removed from the formulary or had some additional attached to it, and then we put the clinical alternative on that letter and provided those to the beneficiaries. Another key differentiator for us in communicating to the members was a Part D insert. So our incumbent PBM helped partner with us and produced an insert. We did a color insert in the members' December EOB statement that highlighted the fact that they had received a new ID card and then some of the key changes that were there. So that helped, again, promote some awareness that last week of December when those EOB statements were coming out. Postcards was something that we sat here in the audience last year and learned quite a bit about and the value. So we decided to put that into our strategy, and it also proved successful. We had beneficiary newsletters, provider directories, and a targeted prescriber letter is the other area I would add that came at the recommendation of CMS that we think about educating our prescribers on what changes we were going to be doing. So we have a Medicare Advantage, we have our own prescribers, but we're also a PDP plan, so that entails some creative thinking for us in engaging with our prescribers. And then Laura also mentioned the industry, trade, and advocacy group engagement with NCPA and SHIPS as just a couple of examples on what we did. Point of sale messaging, this is another one that I would put in the key differentiator category. We had point of sale messaging with our incumbent PBM that messaged back the new plan BIN PCN, but also the RX group information at a member level, so that when the pharmacy received the denied claim, they had all the information they needed to resubmit the claim to our new PBM. And that was important for us. What we also did is we tried to identify where possible to keep the RX group number from our incumbent PBM the same for our new PBM, as that just made one less data entry point for the pharmacist to put in. Pharmacy fax blast notifications, we had a staggered approach. We had our incumbent PBM send out a notification initially that they would no longer be the PBM for WellCare, and then we had our new PBM send out a phased approach of communications, welcoming WellCare, and then also getting into the more detailed plan level information in those communications and all the appropriate routing information that they would need. And we talk about areas of opportunity. This will shift gears a little bit, and we think about all the things that went right and did well. There were certainly areas of opportunity and things that we wanted to call out, sort of risk areas, if you will. First is vendor transition for prior authorizations. For those that are familiar with prior authorizations and loading them in a PBM system, it's complicated. It's very complex. I remember sitting with our regional office pharmacist, Carla Taylor, and she pulled me aside at the end and the meeting and said, I've seen plans that have fallen down in the past, and this is where they struggled, was with prior authorization. So we took that to heart and really looked hard at our prior authorizations, and we started a cleanup process actually within our incumbent PBM system so that we didn't have to make as many drastic changes on PAs. If we could term authorizations at the end of the year before 1/1/2016 and not have any adverse effect to the beneficiary, let's do that. What we're trying to avoid are authorizations in the new PBM system that aren't necessary and can often create audit risk, in that they create and become more restrictive than what the formulary is. So that was something that was important for us. What I would recommend out of this is that the control points, when you're thinking about how to scrub PAs and the volume of PAs, understanding the intent of what the original PA was is incredibly important as you're taking it from your incumbent PBM and loading it into your new PBM. So not to lose sight of that, and then have sort of the critical control points around that load process. Next is a migration time frame. Our new PBM had, based on the Central Standard Time Zone, we had claims processing, not processing for the first hour for our East Coast pharmacies. And I kind of flip back to the critical contingencies. I can assure you that the first few minutes after January 1st were extremely heart-wrenching for a lot of folks, but we quickly realized the basis of that, and we were fortunate that we had more people on a conference bridge than we had claims that were actually being processed and not received. So the message here for us, we actually had a conversation with our new PBM, and we should have pressed a little harder on this particular question. We knew that pharmacies had the ability to process on the East Coast to the Central Time Zone adjudication system, but the challenge was the effective dating of the client. So. Transition period start date. So transition, as we all know, is incredibly important for our members and making sure they have access to those medications. What I would offer here is we developed some enhanced procedures for handling those escalated cases. That took a lot of work and a lot of thought to get that out to our CSRs. We implemented a process whereby members, if they were out of medication, that they had an opportunity and they were impacted and exhausted their transition fill, where we were giving them an additional transition fill. It was something that we spoke with the agency about and felt that it was important, but it was a manual process. So the oversight to that process was incredibly something to think about, and make sure you have the right procedures in place, and making sure these beneficiaries, when they meet the conditions for those critically urgent meds and they've exhausted their transition fills and have not ultimately received a coverage termination yet, that we're able to give them an additional fill. Formulary disruption letters, and this will be the last couple of slides here before we open up to some questions. Formulary disruption letters, we talked about the targeted nature of these letters. They were extremely complicated when we got into thinking not only just the volume of letters, but also the fact that members needed to be able to comprehend what we were trying to convey to them. Their drug was going to a higher tier. The drug wasn't going to be covered on the formulary. Perhaps it had some increased UM or changes in UM, and then finding the clinically appropriate alternatives for each of those. We ended up mailing those letters, I would say mid to late November, which was very late, right around the Thanksgiving holiday, and didn't allow a lot of time for members to react. Although we were, our every intent from our communication strategy starting in October, this particular letter was very late in the AEP period, before the end of, I think it was December 7th. So the recommendation here, having the benefit of hindsight 2020, would be to flip the postcard communication, which we mailed in October, as a, hey, we're going to be making some changes, be on the lookout for some future communications, to sending the targeted formulary disruption letter in October, and then sending a reminder communication with the postcard in the month of late November in that same time frame. So with that, Stacy, I'll open it up to some questions.
Okay, if anybody in our audience has a question, please feel free to go to the microphone in the center of the aisle. All right, we don't see anybody moving out there, so we did receive a question from one of our viewers, and that question is, who were the outgoing and incoming PBMs? And what was the name of the consultant used? What? What'd I do?
Michael, you want to take this?
Did you just answer this?
No, we didn't.
We avoided the topic.
Yeah,
I'm sorry.
We did avoid the topic. Obviously, we had a change in PBMs, and that change was for business reasons, purely business reasons. And maybe I'm going to sound too much like an attorney talking, but if anyone would like to ask me after the presentation, I'd be more than happy to disclose who the outgoing PBM was and who the incoming PBM was. I think the key takeaway for this audience is both PBMs were incredibly collaborative through the process, and that we had a great deal of transparency. And we also had a lot of communication, so the expectations were very clear. We're very fortunate that our incoming PBM was very responsive to the needs and to the changes and to, quite frankly, the level of detail that WellCare put into this project.
I just want to add that it was a strong recommendation of CMS's to exclude the names of those folks for a similar reason, that it's not a promotion of a specific vendor for these services, but rather the process that we work through together. Had we mentioned their names, we would have asked them to be part of the panel, and then we would have been bigger than the audience. So just to keep things focused on the purpose of the conversation, that would have just been extra, not noise per se, but another level of topic that we didn't have time to address.
Okay, thank you. I won't ask any more of those questions. We do have someone in our in-house audience with a question. Please tell us your name and where you're from.
Good afternoon. My name is Sarah Lawrence. I'm with Anthem, and this information was exceptionally helpful. I appreciate your willingness to share. My question is, when you got to the December-January timeframe, and especially around lag files from your prior PBM to your new PBM, to really ensure those January claims came through, the December history in the lag file. Can you speak a little bit about what you did in terms of ensuring all of that was timely, and so members' balances, et cetera, really carried forward timely for January?
I'll be happy to take this one. One of those 19 work streams we had was dedicated to loading of these lag files. We also felt it was incredibly important from a claims history to get that information from the incumbent PBM to the new PBM. We started loading claims history in September, so we were very early in the process. We loaded our member eligibility into our new PBM the first week of September. We didn't have 2016 spans in place, but we at least had the membership there so that we could start some of those activities. So we took a year's worth of claims data and we took it in chunks of a month at a time, and we're sending that data from the incumbent to our new PBM. Once we got to the nitty-gritty down to the December, January timeframes, we moved to a daily load process. and making sure that we were handing off files on a daily basis. And at this point, the whole process had become automated between the two PBMs, and there was very little we had to do other from a health plan perspective other than making sure that those files were being transferred and successfully loaded. And that process went on through January. Thank you for the question.
Okay, I do have another question that was received from our viewing audience. And that question is, what top thing would WellCare do differently?
Well, I'd say the hindsight of 2020 with the member communication letter, the targeted formulary letter being very late in November, we did have a few beneficiaries express some concern and angst that they didn't have enough time to make an appropriate change. Throughout all of our best efforts to be as transparent with these beneficiaries as we could, that is something that I certainly would, having the opportunity to do it again, we would mail that targeted disruption letter much earlier in the AEP period.
Okay. The next question that I have here, of all the recommendations you presented, what was the most effective or most successful?
The most successful, outside of the obvious collaboration with CMS and with our executives, would have to be the communication strategy and really the approach, the multi-pronged approach with the different targeted groups. So hitting the beneficiaries, hitting the providers, the pharmacy network, and then also the key stakeholders that were involved in this process. The SHIPs are huge for us from an advocacy perspective, and making sure that they understood and more or less just promoting awareness of what changes we were making and where they could go if there were questions, right? CMS didn't have to be the direct line. If they had questions, come to us, we'll help provide an answer.
And I just would add that our messaging was very targeted. So it was, yes, everybody got their ANOC in September, but then we took it a step further and each letter was customized to the individual member. And we didn't just tell them that they were going to be disrupted. We told them what they needed to do, and we gave them some alternatives that they could reach out to their physician and discuss.
Yeah, and through our conversations that we had with CMS, again, it was a very open, candid conversation, and the agency said, hey, you have a good communication strategy, but you need more. There's always more communication that can be done, and based upon the population, based upon how confusing this can be for our members, over-communicate. And so we implemented some communication strategies or methods that we had not done so in the past. Postcards was brought up, and we learned a lot about postcards at this conference last year that was probably more effective than what we had initially anticipated it would be in grabbing the member's attention and alerting him or her that there were changes on their way.
From the beginning of your presentation, you talked about upper level management, senior management buy-in, which from our perspective is critical because they hold the purse strings that allow you to apply the appropriate resources that you might not have been able to otherwise. It's such a large burden to make one change than when it's a PBM that's doing multiple delegated functions on your behalf. There are so many moving parts that having the appropriate people trained at the appropriate time and getting letters out, I mean, it comes down to weeks. Like, is this 1 week better than the other? Is my call center perfect on this day and not the next? And that was one thing that I think that you handled very well, is managing up in your own organization as well as ours.
Okay. Well, with that, we are just about out of time, so I would like to thank all of our panelists for sharing their experiences and their best practices today. And it is that time again to evaluate the session. So take out your phones and text your response, or go to the poll EV link, enter A, and follow the instructions. And we are delighted to have with us our next speakers who will share how to identify potential fraud, waste, and abuse and take appropriate actions. From the Division of Plan Oversight and Accountability, Beth Brady, Dominka Howard, and Camille Brown.
Thank you. In this last session of the agenda, our segment is actually broken up into 3 separate topics. The topic I'm going to address is the current schemes and issues that we're seeing in Medicare Part C and D. What you see on this map, and this information is coming from our contractor, the National Benefit Integrity Contractor, are the top 5 states that account for 52% of their investigations in Medicare Part C and D. The map shows the top 5 states, and this is identified with current data to date for fiscal year 16. It's California, Florida, Pennsylvania, New York, and Texas. And this actually, as I mentioned earlier, this represents 52% of their investigations. If you want to round out for the top 10, the remaining 5 states are New Jersey, Georgia, Illinois, Michigan, and Ohio. This graph here represents, from last fiscal year 15, what types of investigation, what schemes that the National Benefit Integrity Contractor actually investigated. You will see number 1 at 31% is drug diversion. If you look at the next 2, billing for services not rendered and misrepresentation of services or products, if you add those 3 up, those 3 percentages, that represents 2/3 of all the investigations. Just moving down the rest of the investigation types, you can see things like kickbacks, quality of care, revocation, and duplicate or fraudulent billing. But we just wanted to share those top statistics with you. Now, twice a year, we offer in-person fraud, waste, abuse training. And the attendees at these training sessions are the plans, normally your special investigation unit staff, sometimes your compliance staff. And as I said, these are face-to-face meetings where the plans, CMS, and law enforcement and the contractors get together to talk about what they're seeing, what they're working on. And we find these training sessions to be very valuable so that we can kind of focus where we need to be. From this last training session, which took place in March, what you'll see here are these topics, these issues that were reported to us by the plans that were in attendance at this session. You will see at the top, DME supplies not received. Specifically, it was diabetic testing strips. You'll see a number of different lab schemes, genetic testing, allergy testing. All of these schemes that you see listed on this slide here were actually then referred by the plans to the MBI Medic for additional investigation. Now, at these training sessions, we also have plenty of opportunity to do network and talking about what issues are being looked at. And by issue, where I make the differentiation is that these are things that the plans are looking at, they're further investigating, and maybe at this point have not yet been referred because they're still looking at it. Our purpose in sharing this information with you is that you can go back and look at your data and focus on these type of things to see if they are affecting what's going on at your plan. And if it's appropriate, after your investigation, it may constitute a referral either to the MBI Medic or perhaps to law enforcement. Again, just highlighting some of the things that you see are billing after date of death, identity theft, both provider and beneficiary, and billing for customized equipment without any face-to-face encounter with the patients. Moving into Part D, these again were recent schemes that the plans reported to us at our training session. You see the first one is substance prescriptions without clinical indication of cancer. Substance is an opioid pain medication to treat cancer pain. A collusion between pharmacies and doctors. Doctor shopping amongst beneficiaries. And again, for these types of schemes, the plans have referred these to the MBI Medic, and they are undergoing further investigation. Now, in a few slides before this, I mentioned very briefly genetic testing fraud schemes. I want to bring this to your attention for a couple reasons. As you can see, the type of things that we were seeing, that we heard about, where these labs were billing for high-dollar, medically unnecessary tests without any specific medical condition or a physician order. Beneficiaries were being targeted at health fairs. They were being targeted at ice cream socials at senior housing or assisted living facilities. And you will also see on the left side of the slide that the MBI medic actually received complaints against one single laboratory. We did issue a fraud alert last year on this topic. We do issue fraud alerts when it's brought to our attention that a scheme is rather widespread. It's with the intention of alerting you to keep you up to date on what we're hearing about, what we're seeing, so that, again, you can look at your data to see if you're being victimized by the same type of scheme. But on the other side, in addition to referrals for law enforcement, our outreach and education contractor frequently provides, through their website, inserts that can be customized by the plans to add to beneficiaries' EOBs. The messaging is the same, specific to whatever the topic is, and then the plan can add their name and their customer service number. So a insert on this particular topic to alert beneficiaries of the schemes and to be aware not to give out their ID to people, that type of thing, was made available last year. And just within 2 months, we know that there were 400 downloads on this insert alone. So we think this is a very effective way to get messaging out to beneficiaries that potentially are victims. And we're very pleased that the plans are actually using this resource that's available to them. I talked earlier, you can see the focus was on providers, and I want to now focus a little bit on beneficiary fraud. Law enforcement is now more actively pursuing beneficiaries with healthcare fraud. The schemes are becoming more brazen and bold. We're seeing an increase in collusion and coordination amongst some beneficiaries, providers, and pharmacies. And we're seeing targeted recruiting efforts trying to encourage beneficiaries to get involved in fraud. So again, we want to bring this to your attention, and next slide I'll go over some of the schemes so that, again, you can look at your data, focus on these type of things, and if you see something after your investigation that you think is a problem, we recommend certainly that you refer it to law enforcement and or the MBI medic. And just now to go over some of the schemes involving beneficiary fraud. At the top you see drug-seeking beneficiaries, identity theft, again I referenced that earlier, relationships and kickbacks with providers or pharmacies, recruiting, high-dollar drugs with high street value, again for big profit, and enrollment and eligibility fraud, attempting to enroll or qualify for low-income subsidy. So I thank you for your time, and at this point I'd like to turn it over to Dominga Howard, who will talk about the next segment in our presentation. Thank you.
Thank you. Awesome. So, good afternoon. I'd like to give you a brief introduction to the new cutting-edge data resource that CMS launched in 2015 to help support investigations. It is already widely used in the Medicare Advantage and Part D stakeholder communities among plan sponsors, law enforcement, the MBI medic, and CMS. So the big question is, what exactly is Plato? Plato is a web-based fraud detection tool that is designed to enhance the Medicare Advantage and Part D programs' oversight and operations. Investigative outcomes associated with pharmacies and prescribers referenced as providers in Plato can be tracked in this Plato application. Plato also helps users identify potential fraud, waste, and abuse leads using data projects, which work to identify fraud schemes using national data summary information. This data information is updated on a regular basis. So the next question is, why was Plato developed? In a congressional hearing in June 2013, congressional members mentioned the need to increase the use of data analytics to proactively address fraud, waste, and abuse in the Medicare Part D program. This mandate was also to address the drug diversion and associated beneficiary and public harm caused by this problem. A solution was needed to proactively address fraud, waste, and abuse at earlier stages rather than the pay and chase approach. Since plan sponsors directly pay Part D claims, a solution was needed to help plan sponsors detect the aberrant activity. Plan sponsors also have claims generated under their respective contracts and don't have access to the entire bandwidth of data that would enable them to better make informed decisions. So prior to Plato, actions taken by one plan sponsor against providers or pharmacies couldn't be viewed by another plan sponsor. Plato addressed this limitation. So some of the benefits with Plato is it allows users to review Medicare Advantage and Part D pharmacy and provider investigative leads. It also makes national data available and shares actions taken by other Medicare Advantage and Part D plan sponsors in real time. Also, it contains data from the Medicare Advantage and Part D pharmacies and providers and offers additional details on those high-risk leads that identified in some of the data project results. So the users within Plato, again, are CMS, law enforcement, plan sponsors, and the MBI medic. So in addition to containing the national summary data, Plato also helps to build an overall picture of provider and pharmacy activity. It is a valuable communication tool for tracking and sharing the results and outcomes of investigative activity. Plan sponsors can see, again, in real time, the actions that have been taken by the high-risk prescriber pharmacies or by the MBI medic or another plan sponsor. Plato allows users to visualize risk category trends for pharmacies and prescribers that fall into a high, medium, or low fraud, waste, and abuse risk category. Users can review detailed business profiles, including such information as the business owners, the location, to assess the extent of relationships between the providers and the pharmacies. So to help support your investigations, CMS developed this cutting-edge data resource that many of you hopefully are using today. So Plato can be an effective asset for your users if it offers a magnitude of information that will aid in the identification and development of investigations. The CMS approved data projects are the key component of Plato, used for identifying potential leads to who may be committing the fraud, waste, and abuse. By using the national data on pharmacies and providers, the MBI Medic developed the data projects that identify the risk factors and areas that are at high risk for fraud, waste, and abuse, and assigns these subjects risk scores. These risk scores help the users recognize the noteworthy subjects to further investigate and review for possible fraud, waste, and abuse. So currently, there are 3 data projects that are loaded within Plato, and in the near future, we'll be loading even more projects. So these 3 projects are the pharmacy risk assessment and the prescriber risk assessment, in addition to the pill mill doctor project. So here's a couple of screenshots of Plato. So the Plato team, we work continuously to improve the tool's functions and to add new features to make it more effective to aid in your investigative efforts. These are a few example screenshots. As I stated, the provider and pharmacy tab shows leads from existing data projects. Users can look at the relationship graph to see how various entities are related and identify others that they may not have been aware of. This graph allows users to see other providers and pharmacies that are linked to the profile that they are reviewing. Filters are available so they can see different relationship types, such as just the provider or just the pharmacies, as well as filtering to see who shares the same practice address, the billing address, or who shares beneficiaries, and more. Users can even select the links and receive a snapshot of information about their such MPIs, risk scores, total paid amount, and the relationships. Okay, there are also detailed MPI reports available within Plato. The reports provide a great amount of detail about the high-risk MPIs within Plato. Users may also use these reports to assist in their investigations. Another feature within Plato is the homepage map. Rather than looking for a list of providers and pharmacies of interest, the map provides a view of the actual physical location of providers and pharmacies on the map. By being able to apply such options and filter criteria, we can see the possible leads in their locations. When selecting a provider or pharmacy pin on the map, you're able to see a small pop-up screen that provides brief details about the provider and pharmacy and select, as well as the ability to access their profile. This small pop-up window also gives users the advantage of being able to see the physical location with a 360-degree street view. This allows you to see exactly what it looks like within that area. So some current stats. Sorry.
We're having a bit of technical difficulty. Just hang on for a moment. And we'll get right back to the presentation. In the meantime, if you have a question for any of our presenters today, remember that open Q&A session is coming up at the end of the day, and we are still taking questions that we can address at that time. So if you were unable to get your question in, please send it in. Also, at the end of today, we will have a survey that will go out to all of the participants, and we do ask that you take the time to complete that survey and tell us about your experience here today so that we can improve upon it for future events.
So thank you.
You're welcome. Back to you.
So back to the Plato stats. So currently there are over 700 users that are taking advantage of Plato's great features. This includes over 380 plan sponsors, CMS, and law enforcement users, in addition to 320 plan sponsors, contract administrators, and MBI medic users. These numbers are continuing to grow as more and more people learn about the collaborative value and analysis features of Plato. So these 700 users have already documented over 3,100 activities, all of which are being shared among Plato users. So some examples of these activities are corrective action plans, payment suspensions, post-payment reviews, provider education, and referrals to the MBI medic or law enforcement. So, thank you very much for taking the time today to learn about Plato. And we encourage all plan sponsors to use Plato in their compliance and investigative efforts. So next, I'm going to turn it over to Camille Brown.
Thank you, Domingo. So good afternoon. I'm going to talk to you a little bit about our self-audit process that we conducted this year. So over the last couple of years, CMS has worked closely with plan sponsors to really try and improve their performance under the Medicare contract. And part of this has been done through our audits, whether it's an on-site audit or a desk review or our self-audits. One of the goals of our audits is to really ensure the appropriateness of program coverage under the Medicare Part D program, as well as ensure the accuracy of billing once coverage has actually been determined. This year, we have embarked on a limited scope of audits, and those audits have really focused on areas that have been brought to our attention as a concern. The limited scope of audits were turned into self-audits this year instead of the actual full scope on-site audits, and they were really intended to assess the effectiveness of plan sponsor compliance, as well as for plan sponsors to utilize those audits as a tool to sort of implement additional measures into their current programs. Also, we really wanted to assess the outcomes of the on-site audits versus the self-audits. So I want to talk a little bit about the subject of the self-audits, how we selected those plan sponsors, and what target areas we actually looked at. What CMS did is that we conducted a data analysis, a proactive data analysis of prescription drug event records for select drugs. And the initial focus was to really look at drugs that may have been inappropriately paid under the Medicare Part D program. We also looked at proactive data analysis to determine what plan sponsors were inappropriately paying for Part D drugs. And based on those results, we developed our scope and our focus of those self-audits. So I'm going to talk a little bit about the audit process itself, because once we defined the scope and the focus of the audits, we began the process. We developed an audit protocol and sent that out to plan sponsors for them to use as an aid in conducting their self-audits. But we first started off with an engagement letter, and the engagement letter really provided some high-level details and expectations of what the self-audit would consist of. It focused on providing information on the contracts that would be under the audit, the period that the audit would cover, as well as the drugs that would be selected for the audit. In addition to that, we provided the anticipated webinar dates as well as the contact dates where we would hold a kickoff meeting. So after we sent out the engagement letter, we did follow up with a kickoff meeting. And the purpose of the kickoff meeting was to really provide, again, an overview of the self-audit process, as well as discuss any issues, concerns, the expectations, and any other logistical concerns. So when we started the self-audit process this year, we really tried to focus on how we could streamline the process, how we could get the most and minimize resources between CMS and plan sponsors. We developed the self-audit process into two phases. We focused on, one, a webinar facilitated process, and then we focused on a self-audit process, which the sponsor was responsible for completing on its own. So the self-audit process was really a process where the plan sponsor was responsible for walking CMS through their systems. It was an opportunity to discuss with CMS how they would provide supporting documentation for the sample PDE records that we identified as inappropriate. One thing we'd like to mention is that during the self-audit process and even during the kickoff meeting, it's extremely important that you have your key folks there that are able to answer questions and to assist you along the process. And that would be folks that would really be in charge of your operational areas, folks that are familiar with your internal policies and procedures, and folks that would be responsible for going and pulling electronic records or entering into your electronic systems to really show CMS how you can support those payments of being appropriate. So again, at the time of the walkthrough, we provide plan sponsors with a sample during the webinar, and we just walk through a couple of those cases. Once the webinar is complete, we do go back and we expect for the plan sponsor to complete that sample. They complete the sample and then they return it to CMS. After it's returned to CMS, we review it and we validate it. When we finish our validation of those results, we contact the sponsor if there are any issues or concerns. If there are not any issues or concerns, we allow the plan sponsor to move forward and proceed with reviewing the remaining PDE records that were identified in that particular universe. Typically, we give plan sponsors 6 weeks to complete the review of those PDE records that are in the universe. Once that is actually completed, we expect for them to send us the final results. After we receive the final results, CMS conducts their own validation and their review. And based on those findings, what we do is we send out a closeout letter. And what the closeout letter includes is basically the findings and the results based on our review. And depending on the focus and what the results and the findings are, plan sponsors may be expected to delete the PDE records. And we give them typically 90 days to delete PDE records that were identified as inappropriately. And throughout that process, while you're deleting the PDE records, we will do periodic checks to make sure that those deletions were successfully processed. So once the entire audit review is completed, we've sort of looked at what are the benefits of the self-audits versus the on-site audits. And rather than doing a full scope on-site audits, we've found that the self-audits are really an effective way to review less complex issues. We also found that plan sponsors, really, they're the ones that are at the forefront. So they're learning themselves what their actual payment errors were and how to correct those errors occurring in the near future. It certainly reduces time between CMS and the plan sponsor. And we are currently conducting a lessons learned as well as a best practice from the self-audits that we recently conducted to improve our current process. So with that said, we will open it up for questions.
Hi, Scott Levine, Affinity Health Plan. It's still not totally clear to me what the plan is expected to do following the webinar. Is the plan supposed to basically review and audit a sample that's selected by CMS, or does it go beyond that? And typically, how large is that sample?
So CMS will send you a sample, and they'll send you a sample 1 week in advance of the webinar, and the expectation is to not go through the entire sample during the review, but select just a couple of cases and let us know how you determined those cases were appropriate.
Okay, and can you give me any kind of feel for typically how large these samples are, or do they really vary depending upon the plan?
Yeah, the samples would really vary depending on the plan.
Okay, thank you.
Okay, our in-house audience, please feel free to step up to the mic should you have a question. And then I do have some questions from our virtual audience. And the first one is, do you consider cases of drug diversion consisting of cash payments for opioids or other controlled substances by beneficiaries as FWA, meaning they bypass the use of their PBP to obtain the medication?
Could you just repeat that?
Sure.
It was a little long, so I just want to make sure I got it all.
Absolutely. Do you consider cases of drug diversion consisting of cash payments for opioids or other controlled substances by beneficiaries as FWA, meaning they bypass the use of their PBP to obtain the medication?
In that situation, I mean, it's certainly not the way that particular drug should be handled. The reason I'm hesitating on saying fraud, waste, and abuse is because the way I understand the question, it's bypassing the Medicare program completely. The way I understand the question, it's like me going to someone out on the street and buying something. I'm not submitting anything to my insurance carrier. And that's the way I understood the question. That it's just strictly a cash transaction, and no program is getting involved in that transaction. It's wrong, but as I said, it's not affecting the Medicare program or any other plan.
Okay. All right. The next question that I have here from our virtual audience, do you have any suggestions or tips for how PDP plans with no access to medical claims data can become more effective in their FWA efforts?
That's a good question. We certainly understand the limitations that PDP plans face. There are, however, a number of things that can be accomplished. Dominica talked a lot about Plato and the benefits of Plato. For those of you who use it, and we hope everyone's using it, as we said, we encourage you to enter the actions that you're taking, the corrective actions. Again, it's not identifying you or your plan as to what who did it, but you're showing that perhaps you removed a pharmacy from your network, or you provided some education. So that's a tool that if you're using Plato, you can see what other plans are doing to correct inappropriate actions. There's a lot of tools that are available on our outreach and education website that again help you in investigation. But I think the important thing that I would recommend, and I think Camille and D'Amico would echo that, is to work closely with your FDRs. I mean, stay on top of things. If you have any questions, if you're not sure, you can reach out to CMS. You can certainly reach out to the MBI medic. If it's appropriate to make a referral, the MBI medic will continue the investigation, bring in law enforcement when needed. So again, we understand the limitations, but we do believe there are some positive steps that can be taken.
Okay, thank you. The next question that I have, can a plan sponsor have more than 2 users per contract number?
So currently, no, but we are looking at possibly later on expanding that number.
Okay. All right. Lots of questions here. Popular group. If we are providing benefits in any of the states that are high in the potential for FWA, is there anything specific we should be doing?
Thank you. The reason we do provide this information, and again, as I said, we provide it both at our face-to-face training programs, is to give you a heads up, basically. If you have business in those states, we're not saying that your plan is effective, but it is to give you the heads up that this situation is going on, these schemes are taking place, and to focus, in your plan for the year, focus on those type of things. That's why the information is being shared with you, so you know whether this is something I need to be concerned about, or for whatever reason I'm not affected by it. But again, we want to share this information so that you can stay on top of it as much as we want to stay on top of it as well.
Okay, thank you. What are the expectations of the audit?
So the expectations of the audit is really for the plan sponsors to collaborate with CMS, to communicate with us, to provide as much documentation as possible when you're conducting your audits in order to support those payments that have been identified as inappropriate. It's also an opportunity to really use it as an educational tool, as a learning tool to sort of identify areas within your organization that you can improve.
Okay, thank you. Can a contract administrator also be a Plato user?
Well, we would prefer not. We prefer for the contract administrator to provide the licenses to other individuals within the organization. The contract administrator, we would hope, is the compliance officer within the organization. So that's something that we would not suggest.
Okay. Our next question. If we identify a new scheme, how can we share that information?
Again, I referenced the training sessions. In addition to the face-to-face training that we provide, we actually offer 2 webinars each year. And webinars are good, don't get me wrong, and it allows an opportunity for those plans that cannot travel to the face-to-face meetings to participate. Our attendance in the webinars is increasing every single time we do them, and we're very, very grateful to the new attendees as well as those who have joined in the past. So that's one opportunity. As I mentioned, bringing CMS into it. You have your account manager. Contact any of us in Center for Program Integrity in DPOA. Talk to the MBI medic. So there's plenty of avenues that we encourage you to use to share this information so that, again, the more information we all have collectively all helps us in combating fraud, waste, abuse.
Okay, our next question. How frequently are the data projects updated?
So they're pretty much updated regularly. The pill mill data project is updated on a monthly basis. The pharmacy risk assessment is updated on a quarterly basis, and then the prescriber risk assessment, that's a static report.
Okay. Next question that I have. is, if we find a similar pattern to what has been identified in a fraud alert, what should we do?
As I mentioned earlier, the purpose of the fraud alert is for us to share with you what we know is taking place. The fraud alert, again, strongly recommends that you look at your own data and not take any action unless it's based on the data that you have seen, not just the fact that we said XYZ is taking place somewhere else. The fraud alerts always have the same messaging at the end. Talk to your account manager, talk to the MBI medic. Again, communication is the key to all of this, so we can all sort it out. But that's what we recommend is to make those contacts if you're unsure of anything.
Okay, thank you. And I do have one more question here. And it is, how can I find out about these quarterly fraud, waste, and abuse training meetings?
Guess this is my time to talk. Our outreach, we do have an outreach and education medic contractor, and their purpose is, as it says, outreach and education. They are the ones that that offer these trainings on our behalf. They have a website, and if you're not already part of that website, we do strongly recommend that you become part of it. Once they go through the vetting process, they will then assign you a user ID and a password. Accessing that website gives you all the information about the upcoming trainings. It gives you links to a number of tools. I referenced earlier, some of the tools I referenced the inserts. We have a fraud handbook to help you how to investigate fraud, waste, and abuse. We have interview guides. We have plenty of information on that website as education tools. The actual website, and I'll read it so I don't mess it up, is http:// medic, MEDIC, outreach.rainmakerssolutions.com. And again, if you're not already a member of that website, we strongly recommend it. Great tools out there, great information, and you certainly will know when we are hosting either the webinars, the quarterly webinars, or the in-person trainings. There's a total of 4, 2 in-person, 2 webinars each year. Thank you.
Okay. And that wraps up all the questions that I had for this particular group. So I would like to thank Beth, Dominka, and Camille for your presentation today, and also ask any speakers who are out there to meet in the speaker ready room so that we can get ready for the open Q&A session. So thank you, ladies. Thank you. I love that you guys are already responding. All right, so it's that time again to do an evaluation of the session, so please take out your cell phones or go to the Poll EV site and type in A and then follow the instructions. Okay, our next session that we are going to have is the open Q&A session that brings all of our speakers back together one more time and gives you one last opportunity to ask any questions that you were not able to ask earlier or that you thought of after the speaker had their session. But before we do that, I just want to give you a couple reminders, and those are, let's see here. To complete the post-webcast survey that will be mailed to you after this conference ends, it's only going to take a couple of minutes, and it provides CMS with some valuable feedback for ways that we can improve upon future conferences. So please take the time to complete that survey. Also, after the webcast, an email will be sent to all registrants when the webcast audio and video files, transcripts, presentation slides, and other information are posted. So keep on the lookout for that. That will be emailed to you once everything is ready and up there for you. Another thing is to obtain your CEU credits for today's event, please refer to page 19 in your conference guide. So if you have any questions about that, please go to the conference guide and look there. All right. Okay, now, the end of session questions. All of our speakers are back with us today, and we are going to go through session by session and ask any outstanding questions of those speakers. So I need my agenda. So our first session today was building effective relationships with your account managers, and we had Judy Flynn and Brenda Suter. So in the audience, if there is anyone with a question for Judy or Brenda, would you please step up to the mic? And I do not have any questions that came in for Judy or Brenda from our webcast audience. And there's no questions from in-house, so Judy and Brenda, you guys do not need to step up. Never mind, you do need to step up.
So I'm Kristen Bass with PCMA. We're the trade association for the pharmacy benefit managers. I just wanted to follow up on there may not be written guidance or regs. One of the things that is perplexing for those who are trying to follow the regs and the guidance is when there are differences among the regions as to what they're recommending that folks do, which is why we rely on the guidance and the regs. So do you have any thoughts on that? Because I think it's pretty reasonable to expect that something would be consistent with guidance and regs. Just saying.
It sounds like what the issue is it's different interpretations. Is that correct?
Yes.
So if you're hearing different interpretations from your account manager, from a marketing reviewer, please tell them that it's different than what's been told by others, and let the account manager know that. And if you're running into the issue, we want to know of differences in interpretation. So you can always let the associate regional administrator know in that regional office. You can let the people know that you work with here in Baltimore. It would be incredibly frustrating to have things interpreted differently, and that's certainly not our intent. Mm-hmm. So please let us know what the issues are so that we can address them. If we don't know that this is happening, we can't help fix it.
Thank you.
Okay, thank you, Brenda. Okay, for session two.
I'm sorry, I have one question.
Oh,
I have one question.
Okay.
Yes, I'm sorry. I'm Christine Johnston from IPC Evergreen. We are a pharmacy consultant, and we assist our plans with their Medicare compliance. And the problem we have with the guidance that you were giving to not ask for guidance is that when we try to work with our PBM, they want us to document why this is necessary, and that the plan's word is not often good enough. So I just encourage you, I guess it's more of a statement, to encourage you to help the plans be compliant with the suggestions, because I think I very rarely have come across a plan that doesn't want to do what CMS is suggesting, but often it's getting the operation to understand what's necessary. So just suggesting.
Thank you very much. We really appreciate it and have appreciated the discussion and the questions from earlier this morning as well. Thank you.
Okay, anyone else for Brenda? Okay. I waited. Okay, our next session, session number 2 today was Encounter Data Update, and that was with Shruti Rajan. And we do have questions for session 2 that were sent in, so I would like to invite Shruti to come up And if there's anyone in the audience who has a question, if you would please move to the center microphone. Okay, our first question that was sent in today, first, Rudy, is who is the contact person in CMS to address questions regarding the merger of two plans into one plan regarding, did we do this one?
Yeah, I can answer it again, but yeah, it's there's two mailboxes. It's the encounter.data.cms.hhs.gov and risk adjustment. Risk adjustment at cms.hhs.gov. So two mailboxes.
Okay. All right, and then one more question that we received says, when will user groups start up again?
Well, maybe I can ask people out there. Does anyone remember?
I do.
Yes,
June 23rd.
that's right. That's
all right.
right, so.
Thank you, Shruti. That was all that we had sent in, and it doesn't look like we have anything from the in-house audience. So thank you very much. All right, the next session of the day was reporting of national and contract level quality scores by race and ethnicity with Madeline Shea. Do we have anyone in the audience with a question for Madeline Shea today? No? Okay, because I do not have any questions from our virtual audience. So Madeline, you get a pass for this one. Moving on, the session that was following that was PDBM Chapter 6, the Part D Formularies Awaken. And Bob and Marie, I would like to invite you up, as I do know we have a number of questions that are still unanswered. And if there's anyone in the audience with a question, please don't hesitate to step up to the microphone. And the first question that we have today is the application of prior authorization that is resolved at POS actually a coverage determination?
Okay, so thank you for the question. That was something that was addressed during my portion of the slides. And again, when an issue is related to a POS edit that is resolved at the point of sale, so allowing the claim to adjudicate under Part D, the claim transaction does not constitute a coverage determination. In those situations where the patient or the prescriber makes either a verbal or written request for coverage of a drug subject to PA or other utilization management restrictions to the plan sponsor, that is a coverage determination, and the plan must process it appropriately.
Thank you. The next question that was sent in, if the plan chooses to consider all compounds as non-formulary, how does the plan notify CMS of this approach? Is noting this in the EOC to the enrollee sufficient?
That question was also during my section, and really a plan wouldn't need to separately notify CMS of that decision. They would just then not list those compounds on their formulary that they do submit. I would just caution kind of hearing that question, though, that things like home infusion, sterile products, TPNs, those can be considered compounds as well, so just to consider that as well.
Okay, thank you. Another question that we received from our virtual audience. What are CMS's expectations for determination of whether or not a Benny is currently taking a PCD when applying PA2 edits on PCDs? For example, would a 6-month pharmacy claim look back for a continuing Benny outside of the transition timeframe be sufficient?
Thank you, Stacy. The answer to this question is found in section 30.4.3 of Chapter 6 of the Prescription Drug Benefit Manual. Yeah, 6 months would be certainly fine. You can choose longer than the guidance that's provided in Chapter 6, but in Chapter 6 it says CMS believes minimum of 108-day look back consistent with other reviews is typically needed to adequately document ongoing drug therapy, but it can certainly be 6 months and beyond. Thank you.
All right. Moving on, same session. Next question. I would like clarification as it relates to the expiration of an approved exception request. If we clearly state in our coverage determination approval letter the date that coverage will end, is it still a best practice to send another notification to the member within 60 days of the expiration, or are we covered with the initial notification?
Okay. I think this was in reference to the example we gave of someone getting a letter stating that their prior authorization or their exception for 2 tablets of the 10 milligram tablet was approved through December 31st. If that date is in that letter, that's fine. Another notification wouldn't need to be sent. However, we wouldn't tell them that they couldn't. I'm not aware of something prohibiting them from doing that practice.
Okay, thank you, Marie. And I think that does it for our questions for the PDBM Chapter 6 presenters. Is there anyone in the audience that would like to ask a question? No? Okay, well, thank you very much. All right. Our next session, Effective Strategies for Addressing Overutilization and Abuse of Prescription Drugs in Medicare, Part D. Do we have anyone in the in-house audience who has questions for our speakers? No? A quiet group today. Okay. I don't have any questions for you. Did you receive some questions? Okay. Could I see those? Yeah. Thank you. Okay. We do have a few questions here, which is awesome. Question number 1, is there further guidance on how safety should be managed for members who have been approved for high-dose MEQD for that hard edit?
Thank you. So we believe this question is asking about those beneficiaries who are identified through Level 3 Retrospective DUR as an overutilizer, and after case management whose use is determined to be appropriate. So what happens to these folks if they subsequently bump up against the cumulative MED opioid POS edit? And as we talked about during the session, exclusions can and should be applied to the cumulative MED edit. This would include those beneficiaries who have already undergone a determination of medical necessity, which could have come about as a result of Level 3 case management. If this was not the intent of the question and the questioner is still listening, please do submit additional details to the Part D formularies or the OM mailboxes.
All right, we do have 2 more questions for Anna and Diane. The second question is, if a MED or Med Hard Edits is implemented by the sponsor at POS, can the sponsor perform a coverage review to assess medical necessity? If so, does the policy criteria used to assess medical necessity need to be approved by CMS? And what is the process for policy criteria review, considering not all opioids are on the formulary?
And so again, I'm not 100% sure we understand the intent, so if we miss it, please email us. But I believe this question refers to the cumulative MED opioid POS edit. And to answer the first part of the question, yes, if the sponsor is using a hard edit, the beneficiary or prescriber may be required to request a coverage determination. To answer the second part of the question, no, the criteria surrounding how medical necessity will be determined does not need to be submitted to CMS. Sponsors are expected to submit details around the cumulative MED opioid edit itself. However, these details are expected to be applied across the entire opioid class, and so it's assumed that non-formulary opioids will also be included.
Okay, thank you, Anna. And the last question that we have for this group. This question involves the abuse of a protected class, in this case, HIV/AIDS drugs. If we find that a member has a persistent pattern of overutilizing such drugs, is a plan permitted to place POS controls or limits on that member?
My question. So, right now, CMS does not have specific guidance for non-opioid drugs, but in the original supplemental guidance that was put out back in 2012, we did talk about other drugs, and what we said was we would expect plans to perform the same due diligence in determining medical necessity as you do for opioids. And later, we did have an HPMS memo that was put out, and if a plan does decide to put beneficiary-specific limits on a beneficiary, or a POS edit limit on a beneficiary, that communication, a copy of that notification letter should be sent to the Part D OM mailbox. And that's it.
Okay, so if there are no further questions from our audience, then I would like to thank Diane and Anna for participating in our Q&A session. Thank you so much. Okay, moving on. Our next session is PBM Migration, Lessons Learned in Part D. Okay. Anyone in our audience have a question? No? Okay, this was our WellCare group, but also we had a couple individuals who were participating from CMS. And the question that we did receive is directed toward these CMS individuals. And that question is, have you ever seen such a level of coordination with CMS and internally among the company on a PBM transition?
I would hate to ever disrespect any previous PBM transitions that have occurred. This was a lessons learned opportunity we built off of the fall presentation, and we're able to work really, really closely with our colleagues at Aetna. And WellCare's transition happened to come right on the heels of that, and we were able to almost in real time apply with the lessons that we were learning. So we were better prepared to assist with this transition than I think we had been previously, and had already implemented all hands on deck approach, and they were able to, I think, benefit from that. Ariane is our specialist on PBM issues in general. When there is something going on with a PBM, she's the one that will reach out and contact the PBM and see how broad spread the issue is, and she may have things to add to that conversation.
Right. As Linda said, we was just on the heels of another big transition where there were some issues we were working very closely with. And the other factor in why we worked so closely was obviously it was a very large transition. It was 3.5 million members. So anytime that happens, we're concerned about disruption on a larger scale than we might see typically.
Okay, any other questions for this group? No? Okay, well, thank you to Linda, Ariane, Michael, Laura, and Lee. And then our last session of the day is Combating Fraud, Waste, and Abuse in Medicare Parts C and D. And I do not believe we have any questions from our viewers. We asked a great deal of questions during the presentation. Is there anybody in our viewing audience in-house with a question? No? Okay. Well, then, at this time, we do have a presenter who is joining us to help close things out today. So with that, I would like to introduce to you Randy Brower.
Wow, so many of you hung in there till the last minute. I am impressed. It's nice to see so many folks I haven't talked to our plan community in a long time. But I'm back, and I'm sure you're all thrilled about that. And you'll be even more thrilled when you hear what I am here to talk to you about, and that is compliance with Section 504 of the Rehabilitation Act of 1973. If this is something that doesn't sound familiar to you, it should, and you should go back to your respective organizations and ask around about this. So in summary, Section 504 of the Rehab Act requires that all of us, you, me, CMS, government agencies, anyone that receives some kind of financial assistance from the federal government, ensures that no one is discriminated against or is prevented or prohibited from receiving services or benefits because they can't have information that they need in a format that is accessible to them. So what I'm talking about, of course, is accessibility, information accessibility, in-person, telephonic, and written materials being made available to individuals in formats that are acceptable and usable by them, such as Braille, large print, audio CDs of your written documentations, qualified readers, and that sort of thing. So there was a memo that came out from HPMS back in September of 2014 that outlined CMS's expectations and your responsibilities in this area. And my office now, I am the director of the Offices of Hearings and Inquiries. And we have taken on the responsibility for 504 compliance across the enterprise for CMS, so for all of our products, Medicare, Marketplace, and Medicaid. And since you all are a group of folks who have been doing business with for a really long time, we want to ensure that we're working with you right from the get-go to make sure that everybody who does business in the Medicare space ensures that our beneficiaries are protected and have access to the information that they need, and that we don't even inadvertently discriminate against someone by not making those things available in those formats. That's really all I wanted to say today, little public service announcement, and also let you know that we'll be coming back and joining our CM colleagues again in June at the Compliance Conference to provide a little bit more information about how we're going to work with you to ensure that we're all doing the right thing for all of our beneficiaries, making sure that they can get what they need. And we'll be providing information and updates along the way. But if you have questions about 504, you can send them on in to me in the Offices of Hearings and Inquiries, and we'll take it from there. So that was it, my little public service announcement. Good to see so many of you. I think you have a few closing remarks, so I will stop here and say thank you.
Okay, we are going to jump back one, and I'm going to ask you one last time to evaluate the open Q&A session. So if you could take out those cell phones or link up to Poll EV for the last time and complete the survey on the open Q&A session, we would surely appreciate it. All right, and that brings us to the end of the conference. I'd like to thank all of you who hung in there with us today. Certainly a long day, and we do appreciate it, but lots of great information for you today. Just a couple of remarks. Thank you to all of our webcast participants and to our in-house guests for participating today, and a big thank you to all of our presenters today. It's a huge commitment, and we really do appreciate the time and effort that you put into preparing your presentations today. So thank you very much. Remember to obtain your CEU credits and to fill out the survey at the very end. That will be emailed to you. And again, we will notify you when all of the audio and video files are posted to the website. Thank you, everybody, and have a great evening.